Hello. So good afternoon all. હું ડૉક્ટર મૌલિક શેઠ, ઓનરરી સેક્રેટરી અમદાવાદ મેડિકલ એસોસિએશન, આપ સૌનું સ્વાગત કરું છું. આજે મારી સાથે આજે જોડાયા છે ડૉક્ટર જિગ્નેશ શાહ સાહેબ, પ્રેસિડેન્ટ અમદાવાદ મેડિકલ એસોસિએશન, ડૉક્ટર મનજીત નાયક અને ડૉક્ટર હિરેન પાટલિયા, જે મારી મેનેજિંગ કમિટીના મેમ્બર્સ છે અને સ્ટુડન્ટ નેટવર્કમાં એકદમ આગળ પડતા છે. આજના ફેકલ્ટી ડૉક્ટર સ્નેહલ પટેલ સર. સો આ બધા વતી આપ સૌનું સ્વાગત કરું છું. મને ખબર પડી કે ગઈકાલે જ તમારી થિયરીની એક્ઝામ પતી છે અને સ્ટીલ તમે બધા આટલી મોટી સંખ્યામાં આજે અહીંયા હાજર રહ્યા, એ બદલ ખરેખર તમને બધાને દિલથી ધન્યવાદ કરું છું. સો જસ્ટ ખાલી 2 મિનિટ અમદાવાદ મેડિકલ એસોસિએશન અને આઈએમએ માટે. સો તમે બધા જાણો જ છો કે અમદાવાદ મેડિકલ એસોસિએશન એ ઇન્ડિયન મેડિકલ એસોસિએશનનો એક ભાગ છે અને એ ઇન્ડિયાનું સૌથી મોટું ડૉક્ટર્સનું એસોસિએશન છે કે જેમાં 14,000થી વધારે ડૉક્ટર્સ એના મેમ્બર્સ છે. સો તમે બધા પણ જેવું તમારું MBBSનું ડિગ્રી મળે, સો બધાને રિક્વેસ્ટ છે કે તમે બધા પણ એઝ અર્લી એઝ પોસિબલ આઈએમએ અને અમદાવાદ મેડિકલ એસોસિએશન અથવા તો જે સિટીમાં તમે જવાના હો એ સિટીમાં તમે આઈએમએની મેમ્બરશિપ લઈ લેશો. અમદાવાદ મેડિકલ એસોસિએશન સ્ટુડન્ટ્સ માટેના જે રીતે પ્રોગ્રામો કરે છે એના સિવાય પણ ડૉક્ટર્સ માટેના, એમના ફેમિલી માટેના એન્ટરટેઇનમેન્ટ પ્રોગ્રામ ગણો, એકેડેમિક પ્રોગ્રામ ગણો, કન્ટિન્યુઅસ મેડિકલ એજ્યુકેશનના પ્રોગ્રામો ગણો, એ બધું અવારનવાર કરતું રહેતું હોય છે. આ વખતે ડૉક્ટર જિગ્નેશ શાહ અને અમારી ટીમનું થીમ હતી બિયોન્ડ સ્કાલ્પેલ એન્ડ સ્ટેથોસ્કોપ. સો આ વર્ષે અમે ઘણા બધા પ્રોગ્રામ એવા કર્યા છે કે જે ડૉક્ટર્સને અને એમના ફેમિલી મેમ્બર્સને નોન મેડિકલ આસ્પેક્ટમાં ઘણી બધી વસ્તુઓ, જેમ કે અમે સ્પોર્ટ્સ એક્ટિવિટીમાં ગણો, ફાઇનાન્સ સેમિનાર ગણો કે એવા બધા ઘણા બધા પ્રોગ્રામ યુનિક સ્ટાઇલમાં કર્યા છે. સો તમારા બધાનો સહકાર આવો મળતો રહેશે તો ભવિષ્યમાં અમદાવાદ મેડિકલ એસોસિએશન આવા નવા યુનિક પ્રોગ્રામો કન્ટિન્યુઅસલી કરતું રહેશે. સો બહુ ટાઈમ નહીં લઉં, હું આજે ડૉક્ટર સ્નેહલ પટેલ સર, જે શારદાબેન હોસ્પિટલમાં પ્રોફેસર છે પીડિયાટ્રિક્સના, એમને હેન્ડ ઓવર કરું છું. થેન્ક યુ સર, પ્લીઝ. યસ મેડમ, ડૉક્ટર ચારુ મેડમ, એમને પણ અમે આજે વેલકમ કરીએ છીએ અમદાવાદ મેડિકલ એસોસિએશન વતી. આપણે નીચે સો જસ્ટ ટેક એઝ અ ટોકન ફોર એપ્રિસિએશન હું ડૉક્ટર જિગ્નેશ શાહ સરને વિનંતી કરીશ કે ડૉક્ટર સ્નેહલ પટેલ સરને એક મોમેન્ટો. ના પ્લીઝ સર, થેન્ક યુ. ડૉક્ટર ચારુ મેડમ, પ્લીઝ. Yes, sir. Thank you.
हाँ थी चार्जर चार्जर नहीं स्लाइड चेंजर लगे सेल के लगे ऑन ऑफ है साइड वाले નહીં તો અહીંથી કરી દઈશું, વાંધો નહીં છેવટે.
સેલ નથી કે શું છે?
હા સેલ ગયો લાગે છે. હશે આપણી પાસે અત્યારે કંઈ? હમણાં જ વાપર્યું મેં પણ કદાચ. Such a huge crowd. It's a testimony of the fact that एग्जाम से पहले डर सबको लगता है, गला सबका सूखता है, मर डर के आगे जोर थी, जीत है. Yes. Just to introduce myself, Professor of Pediatrics, Sardaban Hospital and Natural Medicine and Medical College. Few of you must be using my book, that way you must be knowing me. Exam Preparatory Manual of Pediatrics, Part 3rd edition. Pediatrics in 1 hour is very difficult, I know. Just brush up the things, how to present over there. Exam in medicine and exam in pediatrics is more of an art than a science. How to present yourself over there, how to make fool of that examiner, in the sense, I know you have not gone to the wards, I know you have not read properly or partially, still give an impression that yes, I have been to the wards for 2 months, I have read everything, right? So presentation, body language, etc. is more important than your knowledge. $3 million questions. Melody itni chocolate kyun bani? Isn't it? Unanswered. Kattappa ne Bahubali ko kyun mara? Still unanswered. Bigger than that. And this is every year. But believe me, yeah, PDI is such a subject. But believe me, જે વર્ષે પેપર ટફ નીકળે છે, રિઝલ્ટ્સ લિનિયર હોય છે. So do not worry at all. Yes, the paper was tough. That potassium channel, etc. Do not worry, કોઈ ના આવડે, doesn't matter at all. ઓપ્શનમાં કાઢ્યું હશે. Why this course? First question. Why this revision? You've read whatever book you've been there. I mean, this thing. Visualize yourself after the exams. I want everybody to dance like this in front of your college. Right? Nobody should fail. That's the basic purpose of this course. Exam planning, you must have planned initially UG exam, UG student, my son is in MBBS, I know. 6 months before the exams, Nielsen વાંચી કાઢું, this book, that book. નજીક આવે એટલે senior પાસે જઈને tick important things. Last moment, tick માંથી but most important, right? And last resort would be civil વાળા ખોડિયાર માતાના મંદિર exam ના આગલા દિવસે. That's the only resort. Because medicine and exams are unpredictable, you know. The examiners are unpredictable, the system is unpredictable. However well you have read, you may not be able to answer every time over there because the thing is unpredictable. Examiner no mood, patient no mood, saga no mood, beyond our, control, right? That's why practical exam is an art of showing what you know and hiding what you don't know. It is more of art rather than science, right? નથી આવડતું છુપાવવાનું છે, આવડે છે બતાવવાનું છે. And that too within a fraction of seconds or fraction of minutes you need to show, right? We'll focus on practical exams only, keep theory and backgrounds aside. What to carry over there, what to read is the biggest question. I know you would relax for 4 or 5 days and exam na agla divse bang aayi gayi pachi, right? Vikal theory pati. So what do you read just before the day of exams or these 3 or 4 days? Theory, just revise a few topics I have mentioned. Nephrotic, because they are common in case, theory and practical both. Nephrotic, Thalassemia, SAM, Downs, Febrile seizure, normal growth development. Newborn, just read breastfeeding, jaundice, normal newborn care. This is the basic thing you must go through. Theory again, revise. These questions will be asked in practicals. Practicals, What to read? If you have gone through my book, it's the 19th last chapter. I think it suffices everything. Tables, this, everything. What you read is vaccines, instruments, NRP very specifically, drugs, nutrition, gross calorie values of common things, growth charts, X-rays, just hurriedly go through, history taking, history formats, how to narrate a history, and if you have, like in that book, tailor-made histories you must go through. First and foremost, before you appear for the exams, you know the exam system, you must be knowing just to revise. It's a 100 marks question, practical exams now. 60 marks case, you call it a long, you call it a short case, whatever. One case and one table, 40 and 60. 60 marks is case, right? It is about 90 to 100, you must have received the schedule. 90 or 100 students a day. Is it, right? Still same? I think so. 90 or 100 students a day. Exam starts at about 9. We people enjoy breakfast and then start exam. It starts about 9:30. Everybody is in a hurry to go home, 4:30 or 4. What is left is a few hours to complete those 100 candidates, isn't it? Jagya, now you can join me over here. Comfortable, feel comfortable. Listen, what I meant. Yeah. So, 100 students in 6 hours is a rough calculation. Just calculate, it is 3.75 minutes per student. Believe me, 3.75, not even 4 minutes per student. Just an approx calculation. Aટલી મિનિટ મળશે હિસ્ટ્રી લેવામાં, બોલવામાં, પૂછવામાં, પેલાને ઇમ્પ્રેસ કરવામાં, everything. Right? So, and it is same, it's not GU, it's same everywhere. Few in other universities, 50 candidates a day, but they work only for 3 hours at the end and finish things. So, 4 to 5 minutes a candidate is what you would be given over there. Right? So, you cannot play a Pujara-like game in T20, you need to play like a sky. Street smart થવું પડશે, right? નહીં તો theory બોલવા જઈશું ત્યાં તો won't help, right? Things to carry. I'm brushing up common things. It is impossible to, teach pediatrics in 1 hour. ત્યાં જઈને કેમનું પ્રેઝન્ટ કરું વાંચ્યા વગર પાસ થવું. That is my aim. ઓછું વાંચવા સાથે. Right? Yeah. Things to carry over there. Pediatrics is a special branch in the sense, Tetho obviously. Pen, hall ticket, do not forget. Measure tape, Anthropometry mate. Toys, chocolates for the child to play. Pawing is playing with the child. So few chocolates, few toys, torch, hand sanitizer, newborn case after you must have. Though they are provide કરે છે, but you must carry. Hammer, pulse oximeter optional, but do carry. જ્યારે આવડતું ના હોય ત્યારે નખરા વધારે કરવાના. Right? So do carry a pulse oximeter just to impress the examiner. And of course, most important thing to carry over there is a full cortex, isn't it? Yeah, you need it. Body language. This is a common posture. Now, this is called a fig leaf posture. Try and avoid this posture. દાદાગીરીથી જવાનું, shoulders wide open. ના આવડે કંઈ નહીં, ઘેરગ્યું કોઈ નથી આવડતું. મન નહીં આવડે, બધા નહીં આવડે. Simple, as good as that. Do not show, this fig leaf of a posture. This creates the impression of this fellow is tense. He is hiding your, this was given by Adam and Eve. He was shy and he was hiding his genitals in this posture. Right? So suddenly discovered your nakedness in the sense lack of knowledge. Body language should be proper. Avoid this. I know you're a collegian. I have been a collegian, but one day, please, just a day. Now, history taking. As I said, I'd repeat it n number of times. You would be given 5 minutes over there. 5 minutes history લેવાની છે, however toxic the relative may be. Right? એટલામાં history લેવાની છે, એટલામાં exam questions, viva, everything. So, your body language matters a lot. History is not history. Generally books history in the language of the relatives. It cannot be rubbish. A classical example I usually give is, if a patient case says, that solid diarrhea thema chokrana. You would say solid diarrhea? No. So what I meant is, manipulate our history, right? It takes 10 years to be a doctor. It takes a pair of genitals to become a parent. You cannot use his words, isn't it? Manipulate a little bit. Of course, his tone, but words apna જોઈએ. Time ઓછો હશે, you can bluff. I tell you, you can bluff over there. કાન બંધ રાખજો મેડમ, ના ગમે તો. But practical aspects, the examiner is not going to cross check with the relatives કે તાવ 4 દિવસથી હતો, 5 દિવસથી હતો. History narration should be proper rather than 100% truth. Got my point? Examiner is fed up of taking exam of 100 students a day, 3-4 days. He is not going to cross check at all. Flow સરસ જોઈએ, right? So સગાવાલા cooperative ના હોય, બોલે ના બોલે, doesn't matter. થોડું bluff કરી દેવાનું, but complete your presentation, complete your history properly, narrate it properly. થોડુંક ગપ્પા હશે તો ચાલશે, what I meant, right? Okay. Time management, short of time, as I said, relatives may or may not be cooperative every time. If they're cooperative, that's fair enough. If they are not, still form, fabricate a history. Ardhi ape, ardhi na ape, do not worry. But I need a proper history narration. Nobody is going to cross check with the relatives. Got it? So no excuses that the mummy bar gayi thi, pani piwa gayi thi, and nobody was there, not cooperative. No. You need to fabricate a history, if at all they are not cooperative. Okay? It is different from medicine because informant is different. Start with the word informant, right? First impression that you give to the examiners that I've been to the ward is the informant. Don't start history straight away. Pediatrics is all about informant. So start with the word informant, especially if the mother, tell the informant is mother and reliable. There's no definition of reliability, but fairly reliable is the word you can use. And educated, second, educated, she is a BCom pass or 10th fail or whatever. So informant mother, study till their standard and reliable, right? So reliability of the parents, number one. First impression is the last impression. As I said, I need a full, complete first line. That creates the impression that I feel to nahi kare. Baji, આ line માં જીતીએ છીએ. UG exam, whatever the case, doesn't matter because you don't reach to the examination part most of the times. That 3.5 minutes, I want to kill maximum minutes in narrating history so properly that the examiner does not, you don't fall into trap of examination and treatment, etc. So keep on narrating a proper lucid history and consume maximum time of that 5-minute slot. તો આપણે પાસ જ છીએ, right? First line so easy, but એમાં તતો પપ્પા ના થવું જોઈએ, sort of, right? So long, proper, lucid first line gives the most impression. એટલી કે આને માર્ક્સ બાજુ પર ફીલ તો નહીં થાય. First line when we hear as an examiner, right? Informant is mother, reliable. Just an example. Ajay, 2-year-old Hindu male child, born out of non-consanguineous marriage, and be little slow. ધડ નહીં, ગોખેલું એવું નહીં, little slow. If time, આપણે ટાઈમ કિલ કરવો છે. 5 મિનિટ પતી ગઈ તો કોઈ ફીલ નહીં કરે. ઇશ્યુ એ છે કે 3 મિનિટ અટકી ગયા અને પછી ના આવડ્યું, એ ફીલ થવાય છે. I need to finish those 5 minutes, okay? So informant mother, reliable. Ajay, 2-year-old male Hindu, born out of non-consanguineous marriage, coming from a low socioeconomic class, as per modified Kupuswamy classification. This fellow has a habit of modifying every few years. 24 more kadach modify theu. Residing at Naroda, was admitted in Dash Hospital with chief complaints of. Chief complaints has to be in sequence. Fever since 2 days and cough since 15 days. Na જોઈએ. First chief complaint first. Fever 5 days, cough 2 days, common cold 1 day. Sequence has to be maintained. Agreed? Remember, every patient has a name. Henceforth, patient has this and patient had that. No. Every time you narrate the history, it creates a wonderful impression. Ajay had this and Ajay was doing this. Ajay every time. નથી આવડતું સંતાડવાનું છે મારે, સારી વસ્તુ I need to highlight in my history. That's why narrate, call the patient with his name. Okay? Consanguinity, I'm skipping theory for the want of time. Consanguinity definition આવડી છે બધાને, right? Questions on consanguinity when you speak out the first line, they would be asking. Now, ODP. The word ODP is old-fashioned now. Do not use the word ODP. Books ma change થયું છે કે નહીં ખબર નથી. It is HOPI now. ODP was, once you finish the chief complaint, origin, duration and progress. But the origin, say for example, a Down syndrome, where was the origin? It was antenatal. It is not the origin of the disease that we are describing, right? So especially in pediatrics, this ODP word is obsolete. Do not use. It would only create an impression that you have been to the library and not to the ward. What we use nowadays is HOPI. What is HOPI? History of presenting illness, right? History of presenting illness. Each complaint has to be described in detail. Each complaint has to be described in detail. Once you finish with the HOPI, negative history, in each case, do not avoid this negative history. How to narrate or how to just, in brief, catch that system. Suppose it is RS, write or narrate 1 or 2 or 3 symptoms of the same system. Suppose chief complaint is cough, then no history of breathlessness, no history of common cold, etc. And one symptom of the rest of the systems. That grossly for a UG completes your negative history. Again, whatever the system is involved, 2 or 3 symptoms of the same system, and one symptom of the rest, creates the impression that I have taken a proper negative history. You may not be able to take a very scientific or thorough history, but this suffices. If cough is there, no history of common cold, no history of fever, no history of breathlessness, RAS gayu. CNS wise, no history of seizure, no diarrhea. One symptom from the rest of the symptoms is your negative history. Do not, this is a wonderful weapon, progress inward. Atkine bolvanu છે, because you can elaborate to progress in whatever limit you want. I want to kill time over there. So progress inward means you've really taken the history. It's not that expert has given you the history and you're just narrating. So take time narrating progress inward. Right, progress inward is what happened, repeat the 3 chief complaints. Fever was there, now the fever is still there, fever is not there. Cough was there, cough has increased, decreased, whatever. So repeat the chief complaints in the progress inward. Whatever investigations has been done, patient has been undergone some blood investigation, some urine investigation, some radiology, some lumbar puncture or procedure at the back. So repeat the chief complaints, progress inward. What are investigations and treatments? Some IV fluids were given, some injections were given, whatever. She was explained this. Consume 2 or 3 minutes, 2 minutes in this progress inward. Right? In each case. Past history. You can be a little faster in past, speaking of past history. Common would be similar illness, say nephrotic past ma che ke nahi. Whatever. So similar history in past. Common things would be measles, TB, blood transfusion, hospitalization in past. Common things in every case, blood transfusion, hospitalization, TB, measles in past, or similar illness. This line goes for every case, except newborn and thale. Family history, no history of TB contact in every case, right? Detailed family history in thalassemia. You need to, specifically catch which case has been given and then what details, badhama family history, kacha house, pakka house, pani puri khadi thi, budu carriage khadi thi, na bolwa jaye. I don't have time. So detailed family history is not required in a UG short case, but which case needs a detailed family history, you must understand. So thalassemia, take a break, I need a detailed family history. Rest of them, EG, chal se jawado, skip. And this is not skip, but very fast. Similar complaints, etc. So family history, no history of TB contact, and if it is thalassemia, full complete family history, father, mother, thal minor se ke nahi, other affected children, and a pedigree chart. Only in thalassemia, otherwise family history is just no Cox contact, nothing else. Okay. Family history of birth spacing in SAM. So 2 cases wherein family history would be a little bit of detail, it would be birth spacing word in SAM, because it is one of the causes of SAM. SAM is severe acute malnutrition. And thalassemia, of course, you need a good family history. Similarly, birth history, just 1 line in all cases. Full term normal delivery, hospital delivery. I am a little fast because short of time. Full term normal delivery, hospital delivery, cried soon, uneventful. That suffices everything. Full term normal delivery, uneventful, no hospitalization. Right? Details of birth history only if you get a neonate or a very small 2 or 3 months infant. Otherwise, birth history is 1 line. Details only if it is a newborn or a small infant. Immunization history, again, just ratta marlo 1 line, fully immunized for his age or partially immunized for his age, and BCG scar is present. Do check BCG scar in each and every child except a newborn and an infant wherein the scar may not be still visible. Right. So immunization history, 1 line only. Child is fully or partially immunized for his age as per NIS, and BCG scar is present or absent. But take a break and detailed immunization history in nephrotic and thale. Right. Nephrotic, you need any special mention. Child is immunized for his age and no special vaccines have been advised. Ek line. Or thalassemia, hepatitis B has been specifically bolvanush. So thalassemia, nephrotic, 1 special line that special vaccines have been advised. Otherwise, fully or partially immunized for his age, BCG scar is present. Diet history, again, you cannot go into details of diet, I am very sure, time nathi hoto. Still how to speak out. Normally, child is on full family diet and a vegetarian. Normal, 1 line, common. Exceptions wherein you need to take a detailed dietary history. Breastfeeding in an infant, details of breastfeeding I know, I need. Complementary feeding details if it is a small infant, especially SAM, because there lies the etiology of SAM, right? Sources of iron, if the child is anemia, then diet would be this, and I hardly found any source of iron. I am, exam is marketing. I need to lead the examiner to what I know rather than what I don't know, right? Diet history માં જેવું બોલ્યા that I did not find any source of or any major source of iron. That's all. We tempted to ask you what are the sources of iron, and I am the king then, right? So try and marketing in exams. Special diet in nephrotic and thel, right? Nephrotic માં salt restriction કીધું છે કે નહીં, protein excess કીધું છે નહીં, whatever, any advice is given. So when you narrate a dietary history, normal would be full family diet and vegetarian. Anemia, sources of iron, newborn breastfeeding details, SAM complementary feeding details, and special diet advised in thel, tea, etc., and nephrotic, protein and salt. Got it? One single line. પછી જેને જે કેસ આવે એ પ્રમાણે what special is needed, you need to narrate. Developmental history. Theory માં you must be knowing development, normal development, gross motor, all 4 domains. UG level બહુ detailed ચાલશે, especially in practicals wherein you are not going to get a GDD. GDD is global developmental delay. You are not going to get delayed development children. So detailed નહીં આવડે ચાલશે. Gross, and how to narrate a developmental history, you cannot waste time over there. Developmental history, child is going to school, grown up child હોય તો, and is good in studies. That suffices development. He is going to school and is good in studies or fair in studies, right? DQ only if it is an infant with a GDD, but as I said, you won't be getting a delayed development child, so DQ કાઢવાની જરૂર નથી. Only one line suffices everything. Is child is normal for his, as regards development is concerned, and is going to school, is good in studies. Got it? Development gross આવડવું જોઈએ. Theory I am skipping. પાસ થવા માટે 1 for walk and 2 for talk. This is the parents dialogue. 1 વર્ષે ચાલે એને 2 વર્ષે બોલે. Very gross, but development usually you won't be asked. 2 or 3 points પાસ થવા માટે જોઈએ. Social smile 2 to 3 months, head holding 4 months, sitting 6 to 8 months, standing, walking 1 year. Ask whether the baby sees, hears and listens. This is what is a gross screening for the parents. I think that suffices for a UG also. You won't get a developmental delay child. At the end of the history now, if the first is a perception, last is a very important impression. Most of the times, અહીં આપણો વાયવા પતે છે. 3 minutes are gone, 4 minutes are gone. Examination થી પહોંચ્યા નથી. I need to create a very good impression at the end of my story. Right? What? Always formulate a working clinical diagnosis. Examination રહી જશે, ચાલશે. પૂછવાનું birth history રહી ગઈ, થોડી ઘણી ચાલશે. But be prepared with a working clinical diagnosis. Right? Use adjectives. Don't just say, just a case of fever. No. It's a case of prolonged, unlocalized fever. Whatever. કંઈક લાંબુ જોઈએ છે, thoughtful લાગવું જોઈએ. Right? So be prepared. ત્યાં બોલાતું નથી પછી. Suddenly પૂછે provisional diagnosis. Be prepared with this provisional diagnosis each and every case. Right? How do you write? Suppose it is a respiratory infection. It has to be the condition or the morbidity that is patient is suffering, pathology, anatomy and etiology. Like everything is a guesswork, but you need to be prepared. Say for example, sardi khansi and breathlessness, right? So it seems to be a case of lower respiratory tract infection. If you find rhonchi and consolidation signs over here, then it seems to be a case of lower respiratory infection. Pathology probably pneumonia, anatomy right middle lobe pneumonia, etiology probably viral. Everything is probably, but bole rakhvanu. Got it? So LRTI mostly pneumonia, right upper lobe pneumonia, probably viral or probably bacterial, whatever. Right? So I need a full good line of probable. You may everything may be wrong, doesn't matter. Out of 25 years of practice, મારે ખોટું પડતું હોય. But prepared રહેવું પડે to create a good impression. Clinical diagnosis, right? And be prepared with the summary of the case. Few examiners summarize કરને પોતે સૂઈ ગયા હોય સાંભળતા. Summary is that fellow was sleeping. But doesn't matter. He is the king over there. Summary તૈયાર રાખવાની ફરતી બોલવું પડે. Right? Do not worry using these words. Right? At the end of the viva, usually by and large, કેટલું આવડ્યું તું, કેટલી વાર I don't know બોલ્યો તો nobody remembers as an examiner. This is this side of the chair. કેટલી વાર I don't know બોલ્યો નહીં. કેટલી વાર ઊભો રહ્યો ને, that 10 મિનિટ સુધી એને એક જ ક્વેશ્ચનમાં ઊભો રહ્યો હતો. So I don't know, કેટલું નથી આવડ્યું ચાલશે, કેટલું આવડ્યું is what we check in UG. So જેવું નથી સ્ટ્રાઇક થતું, either I don't know, એના કરતાં better, sir I cannot recollect. જાણે આવડે છે પણ I cannot recollect. Right? Okay. Speak out common things. I know your 16 GB cortex is filled with 20 GB data at present. Those extra GB should not come out in the exams. Right? Speak out common things. બારી ખોલી એટલે કૂતરું જ દેખાવાનું છે, ટાઈગર નથી દેખાવાનો. Right? You speak out કૂતરું, even if you find a tiger. Right? If you speak out rare things, you will be rarely right. Now, when you narrate the histories, few questions એ વખતે would be there. Common would be fever. For any case, fever is a common symptom. So describe fever properly. As I repeat again, I need a thorough, lucid description of the history. I want to avoid examination part, right? So fever pattern is important. Describe the fever in detail. What is fever? You know, fever with rigors and chills. Chills and rigors difference. Chills is what the patient feels because of vasoconstriction. Rigors is the active muscle contraction to generate heat, which we can see. So rigor is what the examiner sees. Chills is what that patient feels. Right? Causes of fever with rigors other than malaria. Malaria Malaria is the least common cause nowadays of. It's not there. That's why. So malaria, UTI, dengue, chikungunya, drug fever, viral fevers. Viral fever first. Every viral fever would give you your rigor. Now, how to remember, how to just speak out one or two associations and symptoms. Causes of fever with rigors, causes of fever, vomiting, fever, jaundice, this. Right. So, rule of two. Rule of two is, in a sense, how to remember. Whatever the symptom, remember or try and narrate one condition of the same system and one from the other. Say, for example, fever vomiting. Where is the gadbad? GI. So, causes of fever vomiting, gastroenteritis. One. You are always right. One more from system beyond the symptom. Right? Vomiting, CNS, pulmonary meningitis. Okay? Badu line, akul list name male chalse. But you cannot stick to that system. Show the examiner that I am thinking beyond the system. That's it. So one from, yeah. 2273 and 1979. ગાડી છે whoever it's on the road towing થઈ જશે એક્ઝામમાં પાસ થવું સહેલું છે ગાડી પાછી નહીં મળે again 2273 and G011 1979 શું છે 1979 whoever towing થાય છે just take care. Okay, so vomiting, since the main system is acute gastroenteritis, second one is CNS, forget. Second, similarly, I'll be fast. Headache, primary is CNS, so acute pharyngeal meningitis. Something else other than the system, a viral fever would give me a headache, malaria can give me a headache. Fever is jaundice, primary is jaundice is liver, so viral hepatitis. One more causing jaundice, malaria, hemolysis, malaria, dengue, drug induced. Similarly, fever is seizures, primary is seizures, CNS, that is either epilepsy, pulmonary meningitis, whatever, and one more non-CNS, electrolyte imbalance. Ek yaad rakho, UG mate, gold medals, there are different criteria, and you all know. But past apne fail nath thau. So one from the system, one from the non-system, right? Fever with rash, two ways: a patient presenting with rash and rash associated. Like enteric fever, rash would be associated, rash dekhai nahi. Whereas few fevers present with rash, measles, maculopapular, vesicular in chicken pox, right? So fever with rash, those presenting with rash, measles, chicken pox, those have associated rash. Example is typhoid. Respiratory symptoms, common questions. When there is cough, as I said, fever, cough, JB complaint, I need a detailed, long, lucid description. Bhale pelo sago bole ke na bole, apne lambu bolwanu છે, right? How do you describe a cough? Cough which is dry, paroxysmal, non-paroxysmal, gradual onset bolwanu છે, right? More at night with post-resuscitation vomiting since last 5 days. These lines, whether the relative gives you history or not, doesn't matter. You need to speak out over there. Right? Dry, paroxysmal, gradual onset, more at night, more in the daytime, with or without post-resuscitation vomiting since last 5 days. What is the importance? Onset. Sudden onset is foreign body, just an example. Gradual onset is an infection. A recurrent cough could be an asthma, right? Or tuberculosis. Duration, acute is usually viral URI. Chronic could be tuberculosis, asthma. Nature, dry cough could be URI. Wet cough, pneumonia. Paroxysmal cough is a common question. Whooping cough, asthma, adenovirus, chlamydia. Whooping cough and asthma, two things important as a cause of paroxysmal cough. Asthma and whooping cough. Right? Okay. Similarly, describe breathlessness. Describe the nose, naak band ho gaya, awaaz aa rahi hai. Describe the sound. If it is nose block, it comes from the nose. If it is stridor, it is extrathoracic airway. If it is a wheeze, it comes from the intrathoracic airway. It is a grunt, it is pneumonia, that is lung parenchyma. Right? Okay. Chest pain. Describe the chest pain, if at all it is there. Location, associated with respiration, associated with food. Left side, right side. The left side chest pain is always non-cardiac. This happens only in Bollywood. It is always lung, and pleura, right? Okay. Vomiting, abdominal pain, every symptom has to be described in detail. Abdominal pain is there, just don't say abdominal pain since 5 days. Timing, character, colicky versus dull aching, severity, reduced by, exaggerated by, released with food, not whatever, and persistent, not persistent. Go on using adjectives, give a big line, right? Diarrhea, you all know, watery diarrhea is viral, usually pediatric watery diarrhea and viral. You need is ORS, zinc and the dietary advice. Rice water is cholera, blood is dysentery. CNS sign symptoms, I am just narrating the common symptoms you would get during the history narration. Seizures, common causes, febrile seizure, do not jump to epilepsy first. Common is a febrile seizure in child and then acute CNS infections, epilepsy, this. Febrile seizure, a common question, badhane pucha se. What do you mean by febrile seizure? Fever with seizure, with fever, 6 months to 5 years of age, without underlying CNS infection, without post-ictal neurological deficit, in a neurologically normal child. Mug up. Febrile seizure nahi avde to fail thawai છે. With fever, seizure with fever, 6 months to 5 years, without underlying CNS infection, in a neurologically normal child, without any neurological deficit. Right? Could be simple febrile, could be complex febrile. One which is lasting less than 10 to 15 minutes is a simple febrile seizure, usually GTCS, single episode per febrile seizure. Right? What is febrile seizure plus? Febrile seizure beyond the age, say 8 years, 9 years, is a febrile seizure plus. Risk of epilepsy is just 2 to 5%. You do not need an EEG. How do you manage a febrile seizure? I don't need an EEG, I don't need an MRI, just in home management. PCM, fever, tepid sponging, intranasal midazolam is what I would prescribe to the parents. Right? Recent concepts, about tactfully bolwana. The range of febrile seizures has changed nowadays. Lower age, they have pulled on till 1 month of age, even at 2 months, you can call it a febrile seizure. Upper age limit has been removed, right? Because febrile plus, seizure plus are quite common. And there's a new terminology called afebrile seizure, means seizure followed by a fever. At the time of seizure, there was no fever. Within 2 hours, suppose fever, we will call it a febrile seizure. We call it an afebrile seizure. But whenever you see a recent concept, pela bhai no ego hurt na thaya, right? So traditionally it used to be 5 months to 6 months, whatever, 6 years, whatever. But the recent concept is this. Let him realize that he doesn't know, but bolo on tactfully. Traditionally it was this. Recent concept is this. Don't jump to straight away recent concept. Nahi to, 1 mahine febrile seizure. This is not the way to speak out. Bhale sacha siye. Traditionally this, newer is this. Alright? As I said, marketing in exams. Causes of epilepsy puche, or causes of seizure in children. I know, only thing under the sun I know is febrile seizure. So causes of seizures in children are febrile seizure. Febrile seizure is very common in children. Simple febrile, complex febrile, tak. Tie a goat and then start describing the goat. Don't give examiner time to ask one more question. Puchu se to kya divert kare and then start speaking. Telo police se puchu do. That fellow would forget what I actually asked. Right? This was history taking. Fear of history taking becomes a history now. I hope so. Provisional clinical diagnosis again at the end of history. Provisional clinical joye, right? Examination very fast. First line, you all know. I have examined the child with proper light exposure. Position is required. Child is conscious and alert or irritable or playful. Points in general examination. Vitals, Anthropometry, IPCOL-V. Signs of SAM and vitamin deficiency, dehydration. Head to toe remaining water is left. Back, spine, genitals. Now, issue with general examination is it consumes 10 minutes of your examination, 10 minutes of narration also. So, which case you need to take a break and detailed general examination versus avoid, be very fast in general examination. SAM is one case wherein general examination itself is a system. Severe acute malnutrition છે એમાં કોઈ સિસ્ટમિક કદાચ ભલે રહ્યું ડાયરિયા હોય AG is a presenting thing, but main examination is general examination. So, SAM માં little detailed general examination is necessary. Other cases, you may just speak very fast, right? Vitals, format, temperature, 98.5 degrees F in the axilla, pulse 100 per minute in right radial artery, regular, right? Force, volume and tension, nahi bolwanu, right? Tension, only person over there feeling the tension is you yourself. Pulse and tension nahi khava padti, it is just in the books. Tension is blood pressure, vessel wall, medicine, Harrison, condition of the vessel wall. Have you ever diagnosed anything using this condition of the vessel wall? No way. So do not speak out rubbish things that are mentioned in the books. Pulse volume, regularity, yes. right? Respiratory rate 34 per minute, regular abdominal thoracic. Blood pressure લેવાય તો લેવાય, ના લેવાય તો બોલી નાખવાનું, except 3 times nephrotic or kidney case. Few things you need to be street smart. ક્યાં ગપ્પુ મારું ને ક્યાં કઈને લઈને ગપ્પુ મારવું. You would be tempted, બેન લીધું હતું બ્લડ પ્રેશર, આ બાંધ્યું હતું પેલું? નો, ટાઈમ નથી, બાંધી કાઢો, નહીં લેતા, બાંધીને છોડી દેવાનું, પણ લેવાનું. નેફ્રોટિક, સો યુ કેનોટ બ્લફ બ્લડ પ્રેશર બીકોઝ ઇટ વેરી ઇમ્પોર્ટન્ટ. આખું ડાયગ્નોસ બદલાશે. અધર પેશન્ટ્સ યસ બ્લડ પ્રેશર દીસ ચાલશે કદાચ. ગોટ માય પોઈન્ટ. નેફ્રોટિક કફ બંધાવવો જોઈએ, આઈડિયલી બીપી લેવું જોઈએ. ઓકે. Anthropometry, minimum things you need is a mid-arm circumference, head circumference, chest, yes, ideally, weight and height or length, right? How to interpret? If weight for age is less, undernourished. If weight for height is less, wasted. If height for age is less, stunted. So take this thing, the anthropometry, try and interpret and give the interpretation rather than giving the figures. So anthropometry suggests child is stunted. Let him ask, right? WHO, I think you must be knowing. Weight for age is less and weight for height is less, acute malnutrition. Weight for age and height for age is less, chronic malnutrition. Weight, height and weight for height is also less, it is acute on chronic malnutrition. Okay. How to speak out now? Mild pallor, no icterus, no clubbing, no clubbing, cyanosis, edema, lymphadenopathy, no signs of dehydration, no signs of vitamin deficiencies. 2 vitamin deficiencies you must speak out is vitamin A and vitamin D. Right? Eyes બોલવાનું નથી, નથી બી બોલવાનું છે. There is no sign of vitamin deficiency. Pull him towards asking you that WHO classification and you are the king then. Right? So no vitamin A deficiency seen in the child, no signs of rickets, no dysmorphic features, etc. etc. પણ બોલવાનું કઈ રીતે? First, because we are short of time over there, first mention the positive things. Do not go on વાળ કેટલા છે, એના માસીના વાળ કેટલા હતા. No. In the sense, short of time છે, you need to speak out positive. Pallor દેખાય છે first. So first speak out the positive things. Pallor, nevus, burn mark. Speak out what is obviously there, may or may not be related. A big nevus somewhere, a vigo inserted over there. Speak out. Lagu jug mein patient joyus sort of, right? And then IV cannula is there, infant feeding tube is there, and the rest of the Ipcol V, etc. Right? Cases, I'll just give you tips on each case. Classical cases, bloated child, happy looking, ramtu, hastu, bloated child is nephrotic. Okay. Nephrotic ma, history would be edema. I need details of that edema. Kill time 5 minutes in describing edema. Right? What's the classical history of description of edema? 2-year-old child, happy looking child, mother complains of insidious onset of edema since last 3 to 4 days. First started on the eyelid, that too upper eyelid. Why eyelid edema? Because it is a loose connective tissue. Acute onset of edema, it presents over here because this is the most loose connective tissue. That is where fluid gets collected over there. Otherwise, cardiac, etc. is a chronic thing. It gets collected in the lower limb or dependent part, right? So, how to describe a renal edema? Insidious onset, otherwise playful child, eating well, starting in the eyes, evening ma jatu rahe, describing in the evening. Over these 3 or 4 days, now the child is feeling edema everywhere, including the genitals. Genital edema, there is no other cause, practically speaking, other than nephrotic. If it is genital edema, it is nephrotic, almost to the extent, rare causes છે બીજા, right? So go on describing the edema, starting ક્યાંથી સાંજે ઘટતું હતું, gradually વધતું ગયું, and still the patient was eating, playing, playful child, right? No itching. Past history, nephrotic માં you will get એક વાર્તા લખે એટલી past history આવશે. 10 વખત દાખલ થયું હશે, every time edema ને ક્યાં ગયા ને do not kill time. આમાં ઊંધું, because it is such a long past history, 3 times admission, every time edema થયો, ક્યાં ગયા, ના મટ્યું, આ કરાયું, તે કરાયું. No. Interpret the past history and give me the conclusion. The child had similar history in past. Every time the child was admitted, was diagnosed as having some renal issue, was given some drugs, and child responded on 5th day. Edema went away. This happened 3 or 4 times in past. Got it? એક લાઇનમાં આખી past history બોલવાની છે. Do not describe each and every event every time. Boring લાગે. Blood pressure માપવાનું છે, લખવાનું છે. Special diet, specially બોલવાનું છે. The child was advised salt restriction or not, whatever. And protein restriction or added protein diet advice કરી હતી કે નથી કરી? Normal is no added salt diet except severe edema and no added protein diet, normal protein diet, right? Though the child is losing, excess protein would cause protein filtration injuries, right? Demonstration, be prepared with ascites, pitting edema. Full diagnosis, ascites hand આવે છે, shifting dullness, fluid thrill, your fluid thrill, shifting dullness, puddle, ભૂલી જવાનું, જિંદગીમાં કરી છે, નથી કરી. I have never done it. I would not do it. I don't know, sir. I have never done it. I have not seen my teacher doing it. Forget. કહી દેવાનું બિંદાસ. But this is theory only. So shifting dullness, fluid threat and horseshoe dullness. Full diagnosis kidney nephrotic don't just say nephrotic syndrome. So this is a 2-year-old child, a case of nephrotic syndrome, second relapse or frequent relapser, steroid responder, everything is from the history. દવા આપે છે મટી જાય છે. So nephrotic syndrome, second attack, second admission, frequent relapser, steroid responder or not responder, whatever. Usually steroid responder, probably MCNS. This completes your nephrotic diagnosis. Why probably MCNS? Answer is most of them are MCNS. Right? 90% બહાર નીકળો તો વરસાદ પડે કે ગરમી હોય ગરમી જોઈએ ત્યારે. So similarly, most of the nephrotic are MCNS, 90% of them. The patient has responded to steroid is equal to MCNS. The age group falls into 2 to 8 is equal to MCNS. That is why probably it is MCNS. So nephrotic, second attack, second admission, steroid responder, right? Probably MCNS. Right? Okay. Last question, બધાને પૂછે છે ISKDC regimen of steroid 2 mg per kg of prednisolone 6 weeks followed by 1.5 alternate day early morning for 6 weeks more, right? Thalassemia. Format changes over here. The child would be there for nothing, for your exams only. So there is no chief complaint. Child is here for academic purpose. First line would be child has no active complaint, is here for his blood transfusion or he is there for academic purpose. બે રીતે આવશે. Either BT લેવા આવ્યો છે or ખાલી એક્ઝામ માટે બોલાયો છે. So ચાઇલ્ડની જગ્યાએ નામ અજય has no active complaint, he is there for academic purpose or Ajay is here for his routine blood transfusion. How to start his HOPI? First time જ્યારે anemia diagnosed થયું હતું, mother felt the child was okay till 6 months, wherein first time mother noticed that child was anemic or pallor or somebody noticed pallor, whatever, and then start describing the blood transfusions. પછી મહિને જતા હતા, 2 મહિને જતા હતા, ક્યાં લેતા હતા, પૈસા થતા નહોતા હતા, BT reactions આયા કે નહીં, is the frequency increasing or decreasing, whatever. Okay. Community you must know. Theory I'm skipping. Diagnosis provisional thalassemia માં સરખું બોલવાનું છે. રાજુ 10-year-old child, Thalassemia Society registered transfusion dependent thalassemia. The recent concept in thalassemia is thal major, thal minor, thal intermediate is gone. Do not use the word thal major. The newer classification is thalassemia transfusion dependent thalassemia versus transfusion non dependent thalassemia. તમારા તો TDT જ આવશે. So this is Raju is Thalassemia Society registered 8-year-old, 10-year-old child. Thalassemia, transfusion dependent thalassemia. Just read the definition from the Google. But thal major कोई बोलता नहीं, निकली गई है. It is transfusion dependent thalassemia, right? On moderate transfusion regime, on chelation therapy, whatever the drug is there, and HIV, HbA1c negative. This completes the whole line of describing a thalassemia. Again, no thal majors, transfusion dependent thalassemia. Google કરી લેજો, ના ખાવ પડે તો. At least in thalassemia case, onset of pallor, a good negative history. What is the negative history in thalassemia? કદી BT reactions નથી આયા. Iron deposition ના each organ ના એક symptom બોલ નાખવાના. Liver, iron deposition, there is no jaundice, no palpitation, like that. Adult છે, grown up છે, adolescent છે, SMR or sexual development history માં negative બોલ નાખવાનું છે કે નથી, કે delayed puberty છે કે નથી, right? Diet history, iron કોઈ advice આપી છે કે નહીં, T. Right? Vaccination, HbA1c, hepatitis B ખાસ. Family history of thalassemia में detail. Demo would be liver, spleen, palpation, જોડે જોડે ascites પૂછી શકે. Final diagnosis again, it should be TDT and not thal major. AG અત્યારે season છે, સખત gastroenteritis ચાલે છે, 50% લોકોને AG આવશે as a case because huge number of candidates. How to describe? Don't just say it's a case of gastroenteritis. Acute gastroenteritis with no dehydration. તમારી પાસે no dehydration જ આવશે, કરેક્ટ થઈને આવશે એક્ઝામમાં. So don't speak out that expert વાળા severe dehydration. એ કે સાઇન નહીં હોય. Right? So acute gastroenteritis with no dehydration, mostly viral, with mismanaged feeding, if at all is there, usually it will be there, with anemia in a fully vaccinated child. બે લાઇનનો diagnosis જોઈએ, not just AGE. Right? Acute gastroenteritis, no dehydration, mostly viral, mismanaged feeding, with anemia in a fully vaccinated child. Demo points. Signs of dehydration આવડું જોઈએ. Skin trigger, skin, sunken eyeballs, dry mucosa, thirst, general condition. WHO, just read and mug up the signs of dehydration. I'm skipping for the amount of time. You must know ORS in detail. You must know signs of dehydration in detail. You must know ABC of correction of dehydration of WHO. આટલું ગોખી કાઢવાનું છે. ABC, plan A, plan B, plan C. ORS in detail. Signs of dehydration in detail. You've gone through. SAM as a case. Severe acute malnutrition. As I said, general examination is the main symptom in SAM. સો થોડુંક ડિટેલમાં જોઈશે. મેન્ટલ સ્ટેટસ ઇરિટેબલ છે, ડલ છે. હેડ, ધ શેપ, સાઇઝ, એન્ટ્રોફ્રન્ટલ મેજર કરવાના. હેર યુઝ્યુઅલી હાઇપોપિગમેન્ટેડ, સ્પેર્સ, થિન, ઇઝીલી પ્લકેબલ. ફ્લેક્સ સાઇન છે કે નહીં. ફેસ આઈધર મૂન ફેસ ઇડીમાના લીધે ઓર ઓલ્ડ મેન લુક. આઈઝ, ડુ નોટ ફર્ગેટ વિટામિન A deficiency in pallor in SAM. Ears, ear discharge. Mouth, vitamin deficiencies. How to speak after diagnosis? Bookમાં નથી રાખ્યું ને, that I'm taking more because otherwise you can read SAM. SAM ના 10 steps etc. you know, right? How to describe diagnosis of SAM? Is a 10-month-old child, whatever, non-edematous, severe acute malnutrition, presented with gastroenteritis with some dehydration or without dehydration, whatever, with or without anemia, with or without vitamin A deficiency, in a partially or fully vaccinated child. Do not stop over there. Main thing is SAM કેમ થયું? ખાવાનું આપ્યું નહોતું 6 મહિને કોમ્પ્લિમેન્ટરી, આપ્યું તો લીધું નહોતું, લીધું તો કાઢી નાખતું હતું, વોટ એવર. દેર હેઝ ટુ બી સમ, એટલું પૂછવાનું ટાઈમ ના હોય તો બી. કોમ્પ્લિમેન્ટરી ચાલુ કર્યું, whether the food was given or not, given, not taken, taken, not digested. ત્રણમાંથી એક હશે. Got it? So etiology being nutritional because of improper complementary feeding as a contributing factor. આટલું સેમમાં ડાયગ્નોસિસ જોઈએ. Got it? આટલું બોલશો તો નથિંગ એલ્સ. યસ, કઈ વાર પૂછાશે નહીં. રાઈટ? ગેટ અનસ્ટ્રક વિથ ધ ફિયર ઓફ ફેલિંગ. ટેકીકાર્ડિયા ના થવો જોઈએ. રાઈટ? થોડું એડ્રીનાલિન રશ ઇઝ ઓકે. મને થતો હતો, આ ચોથી વખત આ સેમ લેક્ચર લઉં છું વિથ ધ સેમ ક્રાઉડ. લિટલ બેટ ઓફ એડ્રીનાલિન રશ ઇઝ ઓકે, બટ ટેકીકાર્ડિયા નો. રાઈટ? ફિયર ઓફ ફેલિંગ ઇઝ ધ ફાસ્ટેસ્ટ વે ટુ એકચ્યુઅલી ફેલ. કોન્ફિડન્ટલી જવાનું છે ત્યાં. એક્ઝામમાં પાસ કરવા જ બેઠા છે, નથી આવડતું, બધાને ખબર છે. આઈ ટેકન ફોર ગ્રાન્ટેડ કે તમને નથી આવડતું, મારે છતાં પાસ કરવો છે. ટુ દેટ એક્સટેન્ટ, ટેક ઇટ ફ્રોમ ઇટ ઇઝ દેર, ઇટ ઇઝ અ ફેક્ટ. કોઈ સ્ટ્રેસ નહીં. થિયરી ઇઝ અ ડિફરન્ટ સ્ટોરી, અઘરું પૂછાયું હતું. પ્રેક્ટિકલમાં એવરી એક્ઝામિનર મારાને પાસ જ કરવો છે, તું ફેલ થઈને બતાય. That's UG. So only thing you need is carry confidence and little bit of cortex, right? Survive at all odds, right? Green pitch છે ને, ટર્નિંગ પીચ છે ને, એક્ઝામના ટોક્સિક છે ને, પેશન્ટ ટોક્સિક છે ને, એલજીમાં આવ્યું ને, સિવિલમાં આવ્યું ને, this doesn't matter at all, especially in UG, right? You have to survive at all odds. એની પીચ ગમે ત્યાં કોન્ફિડન્સ બતાવશો, પાસ જ છો તમે, right? Enjoy the moment. Probably this is the second last exam you'll be facing. એકાદ એમડીની ઓર યુએસએમએલની વોટેવર એક્ઝામ ઇઝ ફન, લાઈફ લોંગ. એક વસ્તુ જે કરી છે ને સડનલી જતી રહેવાની છે. યુ વોન્ટ ફાઇન્ડ એક્ઝામ્સ નાવ. મારે આપવી છે નથી મળતી, રાઈટ? દેટ ટિકી કાર્ડ નથી આપવી તો નથી, જોકે. બટ રિમેમ્બર ધીસ ધ સેકન્ડ લાસ્ટ એક્ઝામ ઇન યોર લાઈફ, રાઈટ? વન પીજી ઇઝ લેફ્ટ ઓર વન યુએસએમએલ ઇઝ લેફ્ટ. એન્જોય ધી મોમેન્ટ. આ નથી મળવાનું લાઈફમાં ક્યાંય. બીજી ઘણી બધી સોશિયલ એક્ઝામ્સ આવશે, પણ મેડિકલની એક્ઝામ્સ નહીં આવે. સો એન્જોય ધી મોમેન્ટ, એન્જોય એવરી મોમેન્ટ. Come what may. Thank you so much. All the best. Two important topics to be covered by Dr. Dhara ma'am, Dr. Charu ma'am. Newborn case and NRP. Two things left. Keep patience. બંને બધાને પૂછાશે. Wait. All the best. Laptop લગાવો. અમારું ચેન્જ કરો. Till they change the laptop. Be very smart in exams, you know. બધા બહુ ભણીને આવ્યા છો. Till she takes over. I know you all are well read. રાઈટ? ત્યાં જઈને આપણું નોલેજ નથી બતાવવાનું, વિઝડમ બતાવવાની છે. ગોટ માય પોઈન્ટ? ડુ નોટ શો યોર નોલેજ ઓવર ધેર. મારો ઈગો હર્ટ થશે, સારું યુજીને આવડે મને નથી આવડતું. નો એક્ઝામિનર સો વેલ રેડ એઝ યુ ઓલ. એનો ઈગો હર્ટ ના થવો જોઈએ. શો યોર વિઝડમ ઇન ધ સેન્સ દેટ ટમેટો ઇઝ અ ફ્રૂટ, યુ નો, ઇટ્સ અ ફ્રૂટ, ઇઝ નોલેજ, બટ નોટ ટુ યુઝ ઇન ફ્રૂટ સેલાડ ઇઝ વિઝડમ, ઇઝન્ટ ઇટ? યા. મારું નીકળી ગયું ને?
થેન્ક યુ.
Welcome our next faculty, Dr. Dhara Gosai, Associate Professor, Head of the Unit, Department of Pediatrics, BJ Medical College.
થેન્ક યુ. So, good afternoon, all of you. Best of luck for your exams. Congratulations in advance. Okay. So, basically, this is a kind of topic which require practical skills. But in exam, everyone who either here or online is attending will get questions from this important topic. So I will not take much time in the theory part, only practical points what we ask in the exam that I'll explain. Okay. Otherwise you all are very thorough with this topic. Just last point revision we will do. Okay. So before starting my PowerPoint, the most important things is in basic NRP and advanced NRP is a flow chart. So try to remember 5 headings. થોડું ગુજરાતી બોલું ગોખી કાઢજો. Okay. So first and foremost is your 5 squares and a titles આવડવા જોઈએ. That is what we ask. So 4 questions to be asked. જ્યારે બી બચ્ચાનો આપણે કોલ અટેન્ડ કરીએ ઓર બર્થ કોલ અટેન્ડ કરીએ, we ask 4 questions. So first and foremost is term or preterm. Second thing, any risk factors in mother, color of the meconium and umbilical cord plan. So try to remember 4 point or 4 questions. Exam માં પૂછીએ છે કે what are the questions you will ask to the gynecologist. Paper જ leak થાય છે તો try to remember. Okay. So 4 questions to ask. Preparation of the birth, that is a second point. Preparation of the birth require preparation of the equipment, preparation of the persons. Third point is single question to be asked after the baby is born. બચ્ચું જન્મી ગયા પછી actually resuscitation will start. So nowadays there is a single question, that is a baby is breathing or crying. Clear? એક જ question પૂછવાનો છે. કોઈ કલર ટોન બધું જાત જાતનું બોલતા નહીં પ્લીઝ. સિંગલ ક્વેશ્ચન, બેબી ઇઝ બ્રીધિંગ એન્ડ ક્રાઇંગ, યસ ઓર નો, નથિંગ એલ્સ. ક્લિયર? સો દેટ ઇઝ અ ફર્સ્ટ અસેસમેન્ટ આફ્ટર ધ બર્થ. આ બધું ડિટેલમાં આવશે પાવર પોઈન્ટમાં. જસ્ટ ટ્રાય ટુ રિમેમ્બર ધ ફ્લો. આફ્ટર દેટ baby is breathing, crying, directly will go to the routine care. Just remember, yes, go to the routine care. No, that is the second part. So in any case, baby is not breathing, not crying, will go for the initial steps of resuscitation. Please mug up. This is your second rectangle square of your flow chart. That is known as initial steps of resuscitation. Just remember PSDSR, that is a mnemonic. PSDSR, that is a mnemonic for initial steps of resuscitation. Clear? P stands for positioning, S stands for suction, D stands for drying, S stands for stimulation, and the R stands for reposition. Clear? Till now koi bhi query ho, you can ask in between. Otherwise we go further. Otherwise flow charts and will get disturbed. So after initial steps of resuscitation, if baby is good, okay, then baby will go to the observational care. So this is a second level of care. One was routine care. This is now observational care. Just remember this terminology. Now, even after your initial steps of resuscitation, baby is not improving. Now we need to assess little bit in a detail, little bit. So that is, now we are looking at the heart rate. In neonatal resuscitation, you have to remember only 2 important landmarks of heart rate. One is 100, another is 60. Be clear. Only 2 landmarks are important. Heart rate 100, heart rate 60. So at this point of time, agar heart rate is less than 100, so that is the most important point of starting બીજો rectangle, that is a positive pressure ventilation. જે આપણે બેગ એન્ડ માસથી આપીએ છીએ ને, દરેક એક્ઝામિનરનું ફેવરિટ છે પોઝિટિવ પ્રેશર વેન્ટિલેશન. સો બી થરો વિથ ઇટ. ગમે તેમ કરીને પકડાઈ દેશે. વોટ ઇઝ ધીસ? વોટ આર ધ પાર્ટ્સ? સો બી ક્લિયર. ધ વર્ડ ઇઝ પોઝિટિવ પ્રેશર ventilation. Clear? So heart rate less than 100, directly go for the positive pressure ventilation. Now, next point is not improving with your positive pressure ventilation. So here, what will be your next step? Again, you have to check the heart rate. So heart rate less than 60, between 60 to 100, more than 100. Between these three, you have to decide your further plan of management. So, heart rate less than 60 at this point of time, that is after already started with the bag and mask, that is positive pressure ventilation. Now it is a time to start chest compression. Please keep this word as a third rectangle. First was initial steps of resuscitation. Second was positive pressure ventilation. Third is chest compression. Be clear with this flow chart. Okay? So, heart rate less than 60. સામે યાદ રાખી લો, that is a landmark for starting chest compression. Clear? Now, we are starting chest compression, but at the same time, we are continuing with that ventilation part also. That is not a point you will stop it and again start the chest compression. So, both the things will go simultaneously. Now, after starting chest compression, we'll again assess this child after a minute. So, if the heart rate is again less than 60, then it is a time for medication. So, this is just an overview. Just keep these titles in your mind. We'll discuss in the PPT in a much detail. In my PPT, I have covered only practical questions, what we ask. I have not covered any physiology, any specific genetic or anything that is required in few cases, not a very high-fi special scenarios. What we routinely ask and we ask to each and every undergraduate students in exam. So please try to remember the flow chart and practical points. Okay? And please, if possible, have one proper video visualization in a NRP, that is a AHA recognized. So you will remember this all flow chart in a pictorial form. Okay? So aims already I have mentioned of my presentation, that is already written here. So algorithm, see, it is like maths. You have to follow the sequence. You cannot directly jump to the chest compression without starting positive pressure ventilation. So be clear, try to follow the algorithm. Yes and no, nothing else. And there is a 3 tier of care. One was routine care, second one was observational care, and third is post-resuscitation care. We'll learn in the next slides in which babies we will go for each care. Sometime we all ask student, what do you mean by resuscitation? So it is basically a Latin word which means to arouse again. Okay, and for all of you, why neonatal resuscitation is, I think you all know, it is a must competency for your undergraduate exam as per the CBME. Pediatrics માં તો બહુ બધી competencies છે. So why this is selected as a must? Because this is one of the common cause of neonatal death in India, in Gujarat, even worldwide. Not just for passing exam, try to remember, it will help you out throughout your life as a doctor. Okay? See, 3 Idiot માં જોયું તું ડિલિવરી કોલ, આઈ થિંક એમાં જે કર્યું છે એને બધું જ નથી કરવાનું. So keep remember that it is not that easy. જે ઊંધું પકડીને મારવું, this is all, that is all good in movie. એનાથી રિવર્સ કરશો ને તો સાચું હશે. But try to remember the flow chart. 85% of the babies, they will not require any resuscitation. You just look at the number. Rest 10%. જે પહેલું રેક્ટેંગલ હતું ને દેટ વોઝ ધ ઇનિશિયલ સ્ટેપ્સ ઓફ રીસક્સિટેશન, એનાથી જ સર્વાઈવ થઈ જશે. બાકી રહ્યા that percentage of the baby only will require advanced resuscitation. તો એવું થાય ને કે આટલી બધી કથા છે એની માટે. See, for you that baby may be one of your thousands patients, है ना? But for their parents that baby is very precious. So you should always anticipate and predict. We never know કે 100 માંથી આ કયું બેબી હશે જેના કોલમાં તમે ઊભા છો. ઓકે, so just we are preparing for that 5% એવું નથી. We never predict. We have to be careful and prepare કે આ બેબીને એડવાન્સની જરૂર પડશે તો મારી પાસે એડ્રીનાલિન સુધીની બધી જ તૈયારી હોવી જોઈએ. Why? The concept is known as a 1 golden minute. આગળ ફ્લો ચાર્ટ આવશે. 1 golden minute is બચ્ચું બોર્ન થાય ને એની 1 મિનિટની અંદર if the baby is not crying, then that baby must be on positive pressure ventilation. That is a target. ખબર પડી? 1 minute. કોઈ વાર છે ને ઘડિયાળમાં બેસીને ટ્રાય કરજો. The way of algorithm is so fast, you cannot prepare in between. જો બેગ એન્ડ માસ્ક અહીંયાથી અહીંયા તમે લઈ શકો ને, that is the actual time. ક્યાંય સિસ્ટરના લોકરમાં પડ્યું હોય, it is not worth to have that. એટલે preparation is must for each and every birth. તમને કોઈ બી ન્યૂબોર્નનો કેસ હશે કે એનઆરપી, this is a sequence of management, TABCD. Please remember, કોઈ બી કેસમાં when we are discuss about the newborn management, it will start with TABC. Why? બધી જ વસ્તુઓ છે ને ઇન્ટરલિંક છે. ફોર એક્ઝામ્પલ, if the baby is hypothermic, તમે પોઝિટિવ પ્રેશર વેન્ટિલેશન આપશો ને તો it will not work. So be careful. The sequence is same for all newborn illnesses and the management. T stands for temperature, A stands for airway, B breathing, circulation and drugs. Clear? Now you just observe the flow chart. It will also follow the sequence what we are mentioning. This is what I have already explained you. Only this is the small one, second last and last. That is actually proportion of the babies which will require the medication and the advanced resuscitation. But we have to prepare all the preparation in each and all baby delivered, even if we are predicting normal. NRP's last, that is the latest algorithm, is as per the 9th edition of NRP, which is given by the AHA. So if somebody asks you, તો તમને ખબર હોય કે 9th is the latest algorithm. There is only few changes are there between 8th and 9th edition that we will discuss as per the protocol and as per the flow. Just have the visualization. If you want to have a pic, you can take a pic. કેમ કે બધે કદાચ નહીં પણ મળે. This is the official flow chart. Actually, एक slide में let then it become difficult to read. So I have break it into the 2 slides. So this is the first part of the flow chart. It will start with the antenatally. Ideally, the team જે બચ્ચાનો કોલ અટેન્ડ કરવાની છે that have to meet the parents antenatally. કે we will be your receiving doctor or pediatrician and we will manage your child after the birth. Team briefing. In a good scenario, 3 to 4 people will be there. તો કોનો કયો રોલ છે that is must to know. Equipment check. I told you preparation of the equipment is must. Now the birth. There is one terminology called management plan. What is the time of cord clamping? Ideal time of cord clamping? 30 સેકન્ડ વડા ખાલી હાથ ઉપર કરો. ઇટ ઇઝ ડિફિકલ્ટ ટુ હિયર. 30 સેકન્ડ કેટલા કહે છે? 1 મિનિટ કેટલા કહે છે? ઓકે, 2 મિનિટ્સ. તો બાકી બધા એનાથી ઉપર જ છે. સો ઇટ ઇઝ 1 મિનિટ. બી ક્લિયર. ઘણી બધી વાર છે ને વી આસ્ક કે વોટ ઇઝ ધ ટાઈમ ઓફ ક્લેમ્પિંગ એન્ડ કટિંગ. સો ધ સેમ ટાઈમ ઇઝ ઇમ્પોર્ટન્ટ. આપણે પહેલાં ક્લેમ્પ કરી દઈએ like immediately after the birth, and if we cut at 1 minute then there is a no roll. So આપણે ક્લેમ્પ કરી અને કટ કરીએ that is at the 1 minute. એનું જે કોર્ડ છે ને that is already attached with the mother. So be clear. Why it is important? Nowadays this is a policy. In 9th guideline they have clearly mentioned at 1 minute you will cut the cord after the clamping. Till that we allow the blood flow જે મમ્મીમાંથી બચ્ચુમાં જશે. It is important to have babyનું good blood circulation. So chances of shock will reduce. ફ્યુચરમાં જે એનિમિયા થતા હોય છે બચ્ચામાં that will also get reduced. And there is so many other factors, but this too is an important point from your point of view. So 1 minute, after that we will cut it. Now only single question, breathing, crying. Then initial steps of resuscitation, which I already told you. Position, PSDSR, just keep that in your mind as a mnemonic. Again heart rate less than 100, then that is a point where we will go for positive pressure ventilation. બાજુમાં એક પિંક લાઈન દેખાય છે સ્લાઇડમાં over this left side, that is the actually time limit for each step. ખબર પડી? So in any case any baby not breathing, not crying, એનું within a 1 minute of time we want to start with the ventilation. Clear? So that is known as a golden minute, golden 1 minute. Now just a further flow chart. If the heart rate is less than 100, the next chart will be your MR SOPA. બધાને ખબર છે Mr. SOPA હે ને? That you just remember that mnemonic. We will discuss later on. તમે ventilation correct બી કરી લીધું, still not improving, heart rate less than 60, chest compression. Still not removing, like heart rate is less than 60, medication. Clear? Now we'll go in much detail. These are the 4 questions I told you. If you want to remember, you can have that as a pick. Okay, 4 questions we are asking in your exam. That is asked before the birth of the baby. Now, how, like we sometimes ask you, how many persons are required? So for each and every birth, 1 person is must who can completely do the resuscitation. In high risk pregnancy, we expect a team which include 2 to 3 persons. In any case, like if we are working in any hospital, there must be 1 person who can immediately attend that call and who can complete the advanced resuscitation skill. Advanced means up to the medication. That person must be available for each and every birth. અને ટ્વિન્સ હોય તો ચાલે, બધાની વચ્ચે એક પેલું બી જોઈ લઈશું, આ બી જોઈ લઈશું. પૈસા બચે ને પ્રાઇવેટમાં તો, આટલા બધા પેડિયાટ્રિશિયનને બોલાવો, નિયોનેટોલોજિસ્ટને તો. સો ઇટ ઇઝ નોટ એક્સેપ્ટેબલ. ફોર ટ્વિન્સ કન્સિડર સેપરેટ ટીમ ફોર સેપરેટ બેબી. ઓકે. This is a list of equipment. Don't try to mug up it. Just go through it. જે વસ્તુની જરૂર પડે છે, we will leave it behind. Don't worry. Now rapid evaluation. So at the time of birth, what we want? Only single question, breathing, crying. Routine care. બધાને પૂછીએ છે હે ને? See, અમુક questions એવા હોય which will mark you pass. પાસ કરવા જ બેઠા છીએ. ઓકે, સો ડોન્ટ હેવ દેટ સ્ટ્રેસ. એમાં છે વન ઓફ ઇટ ઇઝ રૂટીન કેર. આ તો આવડવું જ જોઈએ હે ને? વી આઝ ધ કમ્પોનન્ટ ઓફ રૂટીન કેર. રૂટીન કેર કોને જશે? જે બચ્ચું ક્રાય કરી ચૂક્યું છે, વેર વી ડોન્ટ વોન્ટ ટુ ગો ફોર ફર્ધર. વોર્મથ, મેં કહ્યું હતું ને TABC યાદ રાખજો. સો યુ હેવ ટુ મેન્ટેન ધ ટેમ્પરેચર. ઓકે, so provide the warmth. Nowadays there is one concept known as a zero separation policy. What do you mean by zero separation? It is a part of your routine care. That means immediately after the birth we are not separating any baby from his or her mother. Okay? So even we have not cut the cord, during that time we are supposed to keep that baby on mother's chest, between the breast. This is for all normal newborns who are actively crying and active babies. Be clear. After 1 minute we will cut the cord. Before that time the baby will be attached with the umbilical cord, with placenta, with mother. We will keep on the bed chest of a mother. So mother's direct skin to skin method, જે આપણે KMC પૂછાય છે ને દરેક એક્ઝામમાં. So that is a way for normal newborn also. Skin to skin contact. In normal newborn, drying is important. બધા બોલે છે ડ્રાય કરીશું, પછી કહીએ ને કે ડેમોન્સ્ટ્રેટ કરો બચ્ચું ડ્રાય કરવાનું, પછી એની અંદર જ રેપ કરી દે. એક્ઝામિનરની પાસે માંગવાનું કે આઈ વિલ રિમૂવ ધીસ વેટ લિનન, પ્લીઝ ગીવ મી ધ અનધર સો આઈ કેન રેપ ઇન અ ક્લીન ડ્રાય લિનન. એટલે જાણી જોઈને બાજુમાં જ પડ્યું હોય છે, ડોન્ટ વરી. સો આસ્ક ફોર ધ 2 linens. One is for drying. We will remove that wet linen. બધું ઇમિટેટ કરવું પડશે because we will be having mannequin over the table. And then you just say that I will cover this baby in another dry pre-warm linen. So keep that in your mind. Positioning of a head and neck. Chest to chest position ma baby hoy, so you have to keep the baby's head face towards the lateral side. તો કોઈ બી secretion હોય then you can go for the suction. It is not mandatory and must in all the babies. Suction પૂછીશું કે બધામાં કરવાનું? No. If you see visible secretions obstructing your airway, then and then do it, otherwise not required. Most important point is establish breastfeeding. Nowadays, in all the vaginal delivered babies, it is must to establish the breastfeeding even before the baby and mother shift out of a labor room. So that's why it is a zero separation policy. Immediately post birth, the first and most important part is your exclusive breastfeeding practices will start immediately after birth. Even in cesarean section, gynec વાળા બૂમો પાડતા રહે, આટલો એરિયા આપી દેવાનો. This is our part. So we always try to keep, but it is important zero separation. Clear? વિટામિન કે નું બધાને ખબર છે? એક્ઝામમાં પૂછીએ છે કે કયા વિટામિન્સ છે કે જે બધા ન્યૂબોર્નને આપવાના. એક છે વિટામિન કે, that is IM. વિટામિન D, up to infancy we have to give to all the newborns. Clear? Already we have discussed this. આમાં ખાલી છે ને try to remember the photos. કઈ રીતે મેનેજ કરશો with the mannequin, because ટેબલ ઉપર તમે એકલા જ હશો. So try to remember these photos. હવે છે ને we are discussing the babies who are not breathing, not crying. જે બેબી બ્રીધિંગ ક્રાઇંગ ના કરતું હોય એનો કોડ ક્યારે કટ કરવાનો? ઇમિડિયેટલી. This is again a good question. પૂછતા હોય shall we wait for 1 minute? તો golden minute પતી ગઈ. So not breathing, not crying baby, immediately cut the cord, clamp the cord, shift to the radiant warmer. This will be your sentence. તમને શું કરશે? સિનેરિયો આપશે in exam કે this baby is born, baby is not breathing, not crying, how will you manage? Then now your management will start. I will immediately cut the baby's umbilical cord, clamp it and shift to the radiant warmer. Clear? આટલું વાક્ય યાદ રહ્યું? Cut, clamp and shift to the radiant warmer. So that will complete your warmth part. This is a warmer, it's okay, not required. તમારે બોલવાનું છે. Positioning. પોઝિશનિંગમાં એવું યાદ રાખો, દેટ ઇઝ અ સ્નીફિંગ પોઝિશન. આપણે કોઈ બી વસ્તુને સ્મેલ લેવું હોય તો દેટ વે લાઈક ધીસ. ગોખવાની જરૂર નથી. હંમેશા એટલું યાદ રાખો, ઓવર ફ્લેક્શન, ઓવર એક્સટેન્શન કરીને યાદ રાખો તો ભૂલાશે નહીં એક્ઝામમાં. ટચ કરો ચીન. નાવ ટ્રાય ટુ બ્રીથ. કરો યાદ રહી જશે. થોડું ફ્રેશ થઈ જવાશે, ઊંઘી જશો. બહુ રાત્રે વાંચ્યું હશે ને. Now do the overextension. Your trachea will get compressed. So the best thing is, okay, neutral position. એટલે એક્ઝામમાં કેવું હોય છે, અહીંયા મેનિકિન હોય છે, શોલ્ડર રોડ થોડુંક દૂર હશે. સો ટ્રાય ટુ ફાઇન્ડ આઉટ ક્યાં છે, અને મેનિકિનની નીચે મૂકજો. મેનિકિન એટલે શું ખબર છે ને? થેન્ક યુ. સો યુ કીપ અંડર ધ શોલ્ડર. ભલે એ વખતે ચેસ્ટ રાઇઝ થાય કે ના થાય, ટ્રાય ટુ ફોલો ધ સ્ટેપ્સ. એટલે શોલ્ડર રોલ શોધજો, કીપ અંડર ધ શોલ્ડર્સ એન્ડ સે કે આઈ વિલ મેનેજ ધ પોઝિશન બાય યુઝિંગ શોલ્ડર રોલ. ડ્રાઇંગ, સ્ટિમ્યુલેશન એન્ડ રિપોઝિશન. જ્યારે બી આપણે ધીસ ઇઝ ટુ થિંગ્સ વિચ વિલ ગો સાઇમલ્ટેનિયસલી. એટલે એવું નથી કે એકવાર ડ્રાઇંગ થાય છે, બીજી વાર સ્ટિમ્યુલેશન થાય છે. બોથ ધ થિંગ્સ વિલ ગો સાઇમલ્ટેનિયસલી. વોટ ઇઝ આઈડિયલ વે ઓફ સ્ટિમ્યુલેશન? ટેપિંગ જતું રહ્યું છે, બી ક્લિયર. બેક રબ. બેક રબની ઇન્ટેન્સિટી એટલી હોવી જોઈએ કે બચ્ચાની સ્કિન ના નીકળે. સો વેન એવર યુ આર મેનિકિન ઉપર બી ડેમોન્સ્ટ્રેટ કરો તો બી જેન્ટલ, બિકોઝ ઇટ વિલ નોટ લુક ગુડ. બહુ જોરથી. સો બી જેન્ટલ. એ તો મેનિકિન જ છે, વિલ નોટ ગેટ ડિસ્ટર્બ વિથ યોર મેનેજમેન્ટ, બટ શો યોર એમ્પથી કે ધીસ ઇઝ અ ન્યૂબોર્ન. કન્સિડર દેટ મેનિકિન એઝ અ ન્યૂબોર્ન. અમુક વાર તો છે ને આમ ધડ દઈને માથું પછડે, એટલે ઇવન વી ફીલ બેડ ફોર યુ. સો ડુ જેન્ટલ હેન્ડલિંગ. ઓકે. So drawing ma you have to specifically say baby's maximum larger surface area is a head. So I will start from head, chest, abdomen, limbs and axilla and groin. This is a sequence. Clear? Head, chest, abdomen, groin, axilla and gluteal region. Plus when you are doing a drawing over the back, simultaneously you will go for the stimulation. Again you will say, I will remove the wet linen and use the no second dry linen. This is a question we ask. IFT જોઈ છે, સક્શન કેથેટર જોયું છે? કોઈ પૂછે ને એક્ઝામમાં તો અલાઉ કરે તો પાછળ ફેરવીને વાંચી લેજો પ્લીઝ. મોસ્ટ ઓફ ધ ટાઈમ વી હેવ સીન કે IFT જે હોય ને, ઇન્ફન્ટ ફીડિંગ ટ્યુબ ઓર રાઇલ્સ ટ્યુબ, એને સક્શન કેથેટર કહી દે, પછી કહેવું પડે પાછળ ફેરવું. સી વી આર ઇન્ટરનલ. આપણી ફેમિલી બાજુ ના હોય ને, પિયર પક્ષ ના કહેવાય. સો વી ઓલવેઝ ટ્રાય ટુ હેલ્પ યુ આઉટ. એટલે ઈશારો કરીને કંઈક પાછળ વાંચીને તો બોલે એટલીસ્ટ જોઈ લે. એટલે કોઈ અલાઉ કરે તો ટ્રાય ટુ ઓલવેઝ રીડ ધ નેમ એન્ડ ધેન આન્સર. બધું એક જેવું જ લાગે એક્ઝામમાં. રાઇલ્સ ટ્યુબ છે, સક્શન કેથેટર છે, અમ્બિલિકલ કેથેટર છે, ત્રણેયમાં પ્રોબ્લેમ થતો હોય છે. સો બી ક્લિયર, ટ્રાય ટુ રીડ, પછી ડિસ્કસ કરી લેજો. આ બી પૂછીએ છે, વોટ ઇઝ અ સિક્વન્સ? સિક્વન્સ ઓફ સક્શનિંગ. સો ABCD યાદ રાખજો. M બિફોર N. પછી પૂછીશું કે વાય ઇટ ઇઝ M બિફોર N? બિકોઝ, સાંભળી લો પ્લીઝ, બિકોઝ વેન યુ ડુ ધ નોઝ સક્શન, મેં કહ્યું છે માઉથ પહેલાં કરવાનું છે, નોઝ પછી. બાય મિસ્ટેક કોઈને ખબર નથી અને ડુ ધ નોઝ સક્શન, વોટ વિલ હેપન? જે માઉથની અંદર સિક્રીશન હશે that will directly get aspirated because you are stimulating that part. That's why mouth is always first. Be clear. કેટલી length of insertion એ બી પૂછતા હોઈએ છે. So that is approximately 4 cm for the mouth, 1 to 1.5 cm for the nose. એનાથી વધારે ડીપ સક્શન નથી કરવાનું, અધરવાઇઝ વેગલ સ્ટિમ્યુલેશન થાય એન્ડ બેબી વિલ વેન્ટ ઇન ટુ ધ બ્રેડિકાર્ડિયા. સો બી કેરફુલ. લેન્થ ઓફ સક્શન કેથેટર ઇન્સર્શન 4 cm એન્ડ ફોર નોઝ ઇટ ઇઝ 1 to 1.5 cm. સક્શન કરો, તમે ઇમિટેટ કરશો, સ્ટ્રેટ નહીં જવા દેવાનું માઉથમાં, ઓવર ધ ફોલ્ડ્સ. ડુ ઓવર ધ ફોલ્ડ્સ લેટરલી, કેમ કે વચ્ચે તમારું નર્વ સ્ટિમ્યુલેશન વિલ ગેટ. So bradycardia can happen. Now we have done with the initial steps. This is the most important part of your resuscitation. Please remember, most important step of resuscitation is positive pressure ventilation. We ask you in exam, so what is the indication of starting positive pressure ventilation? Please give full answers. બધા શું કહેશે કે heart rate less than 100. You are not wrong, but it is incomplete. So, heart rate less than 100, but after the completion of initial steps of resuscitation is the indication of starting positive pressure ventilation. Clear? આખું વાક્ય બોલજો. સેકન્ડ થિંગ, તમે બેબીને જુઓ છો, બેબી ઇઝ ગેસ્પિંગ. ગેસ્પિંગ એટલે સાદી ભાષામાં શું કહેવાય? ડચકા. ટર્મિનલ ઇવેન્ટ જોઈ હોય ને કોઈ બી ઇન એડલ્ટ ઓર પીડિયાટ્રિક ઓર સમથિંગ, ન્યૂબોર્ન. સો gasping is the indication where you have to start. બહુ ફેવરિટ છે બધા એક્ઝામિનરની એમ્બુ બેગ. કંઈ ની ફોટો પાડી લો, પાર્ટ્સ જોઈ લઈએ. એટલું યાદ રાખજો, યુ હેવ ટુ નો 2 ઇનલેટ છે પાછળ, જે લેફ્ટ સાઈડ છે દે આર 2 ઇનલેટ્સ. એક મોટું હશે, that is for reservoir, અને એકદમ નાનું હશે એની નીચે, that is for oxygen inlet. ખબર પડી? 2 ઇનલેટ હશે towards the end, ઉપર હશે અને મોટું હશે big circle, that is for attaching reservoir. એની નીચે હશે very small, જેમાંથી ખાલી oxygen tubing can get inserted, that is for oxygen. Clear? 2 inlet. માસ્ક લગાવવાની જગ્યા છે, that is a patient outlet. આ 3 પાર્ટમાં ક્વેરી એટલીસ્ટ ના થાય. ટ્રાય ટુ સી દેટ. વોટ વી આસ્ક? કેપેસિટી ઓફ ધીસ બેગ. સો દેટ યુ નો, આઈ હેવ ઓલરેડી રિટન. વાલ્વ્સ પૂછતા હોય છે, હે ને? વાલ્વ્સ, દેટ ઇઝ મોસ્ટ ઇમ્પોર્ટન્ટ ક્વેશ્ચન્સ. જે બંને ઇનલેટ છે ને, ઓક્સિજન ઇનલેટ અને રિઝર્વાયર, ધીસ ઇઝ ઓલ વન વે વાલ્વ્સ. અપાર્ટ ફ્રોમ દેટ, એક સેકન્ડ, આઈ કેન નોટ પોઈન્ટ આઉટ. એક પોપઅપ વાલ્વ દેખાય છે, યુ ઓલ નો. 6 નંબર બધાને પૂછાશે, વોટ ઇઝ અ રોલ ઓફ ધીસ વાલ્વ? દેખાય છે? ટ્રાય ટુ સી 6 નંબર વેલ. પ્રેશર રિલીઝ વેલ. ઘણીવાર ઇફ સમવન ઇઝ ગિવિંગ એક્સેસિવ પ્રેશર, then that pop-up valve will come up and excessive pressure will release from that valve. So that is known as a pressure release valve or pop-up valve. ઘણીવાર એક્ઝામિનર શું કરે ખબર છે? એની અંદર છે ને સ્ક્રુઈંગ જેવી મુવમેન્ટ હોય છે, બંધ કરી દે. પછી તમે આમાં આપશો ને તો ઇટ વિલ નોટ ગો અપ એન્ડ ડાઉન. ક્લિયર? તો છે ને સ્ક્રૂની જેમ અનસ્ક્રૂ કરી દેજો સ્લોલી, દેન યુ વિલ ગેટ દેટ મુવમેન્ટ કે એક્સેસિવ પ્રેશર આવે તો હાઉ વિલ યુ દેટ વાલ્વ કમ અપ એન્ડ ડાઉન. ક્લિયર? એક છે ને પેશન્ટ આઉટલેટ છે ને જ્યાં, ઇફ યુ કીપ દેટ આઉટલેટ લાઈક ધીસ અને જ્યારે મૂવ કરશો યુ વિલ સી અ સ્લીટ લાઈક વાલ્વ. બધાને પૂછતા હોય છે વોટ ઇઝ અ રોલ ઓફ દેટ વાલ્વ? દેટ ઇઝ અ ફિશ માઉથ વાલ્વ. સો ફિશ માઉથ વાલ્વ છે દેટ અલાઉઝ યુનિડાયરેક્શનલ ફ્લો ઓફ ઓક્સિજન. પાછળથી ઓક્સિજન બેબીના માઉથ સુધી જવું જોઈએ. દેટ ઇઝ અ ફિશ માઉથ વાલ્વનો રોલ છે ટુ અલાઉ ધ યુનિડાયરેક્શનલ ફ્લો ઓફ ઓક્સિજન ફ્રોમ ઓક્સિજન સ્ટોર્સ ટુ ધ બેબી. ક્લિયર? તમને લોકોને પેલું પૂછતા હોઈએ છે વોટ ઇઝ અ ફૂલ ફોર્મ. બહુ સિલી ક્વેશ્ચન છે. સો ઇટ ઇઝ આર્ટિફિશિયલ મેન્યુઅલ બ્રીધિંગ યુનિટ. ક્લિયર? આમ છે ને there is a scientific terminology that is for this bag is self-inflating bag. Why it is known as a self-inflating bag? Because તમે એને જ્યારે બી પ્રેશર આપીને when you allow it, it will come back, recoil back and it will got self-inflation. So this bag will not require continuous oxygen flow to keep it working. That's why it is known as a self-inflating bag. બીજી બેગ જોઈ છે? એનેસ્થેશિયા બેગ જોઈ છે? ગ્રીન કલરની હોય છે, વિચ ઇઝ ઓલવેઝ કોલેપ્સ. સો દેટ ઇઝ રિક્વાયરિંગ ઓક્સિજન. ધીસ બેગ વિલ નોટ રિક્વાયર ઓક્સિજન. ઘણીવાર એક્ઝામમાં પૂછતા હોઈએ છે we just give you the bag. એની પાછળ છે ને રિઝર્વાર નથી લગાડ્યો, ઓકે, ઓક્સિજન બી નથી લગાડ્યો. સો હાઉ મચ FiO2 that bag will deliver to the patient? No reservoir, no oxygen, just bag. You are giving ventilation with that bag. તો કેટલું FiO2 જશે? Room air, please remember. So it is 21%. બધાને પૂછતા હોય છે. So no reservoir, no oxygen tubing, FiO2 will get is 21. Now imagine the second scenario where reservoir is not attached. Tube જેવું જ હોય છે, which is seen as a corrugated tube. એ નથી લગાડ્યું. Just we have attached oxygen અને full flow ઉપર ચાલુ કરી દઈએ તો કેટલું FiO2 deliver કરશે? There is no reservoir and high flow of the oxygen is going on. So 40 to 50%. And when you attach everything like reservoir with oxygen, then and then baby will receive up to 80% to 100%. Clear? So these questions we ask along with the parts of this bag. The most other important question is how to check the functioning of this bag. કોઈ એવું પૂછે ને કે બેગ બરોબર છે કે નહીં, એ કઈ રીતે ચેક કરવાનું? સો ફર્સ્ટ ઇઝ યુ વિલ લુક કે બેગની અંદર ક્યાંય બી ક્રેક્સ છે કે નહીં. મોસ્ટલી જ્યાં વેલ્વ્સ હોય ને ત્યાં ક્રેક્સ હોય. સો દેર ઇઝ નો cracks over the bag, rubber bag. Second thing, with mask, if you grip that bag in your hand, you will feel the air is coming. You will feel the pressure over your palm. That way you have to demonstrate whether the bag is functional or not. Otherwise, it will be not functional. And third point, most important, when you release the bag, it will come back to the normal position. If there is any leak, the bag will not come back to the original position. 3 points to check the proper functioning of the Ambu bag. Mask. What should be the criteria of mask? Mask એટલું હોવું જોઈએ, should cover the nose, mouth, but not should go beyond the chin or over the eyes. Otherwise, the seal will not be proper. Please have a look over this. This is the latest guideline for providing FiO2 and PIP. These all are the credit questions. જો આવડી જાય તો થોડા વધારે માર્ક મળી જાય. ઓકે? Now, once you start the positive pressure ventilation, 15 seconds પછી assess the heart rate. જો heart rate બરોબર નથી તો એક વસ્તુ યાદ રાખો, ventilation corrective step. મિસ્ટર સોપા તમારા બધાનું હે ને? V says MR SOPA. You have to remember MR, SO, P and A. So પહેલા છે ને બે સ્ટેપ વિલ ડુ સાઇમલ્ટેનિયસલી. માસ્ક એકવાર રીપોઝિશન કરીશું, શોલ્ડર રોલ હટી ગયો હોય તો મૂકીશું. વી વિલ અગેન સ્ટાર્ટ ધ પોઝિટિવ પ્રેશર વેન્ટિલેશન. બચ્ચાની ચેસ્ટ છે ને, દેટ ઇઝ ઇમ્પોર્ટન્ટ. ચેસ્ટ રાઇઝ થતી હોય દેટ મીન્સ યુ આર ગિવિંગ પ્રોપર વેન્ટિલેશન. ઇમ્પ્રૂવ ના થાય દેન SO. S ફોર સક્શન, O ફોર ઓપન ધ માઉથ. ઘણીવાર ન્યૂબોર્ન્સ છે ને માઉથ ક્લોઝ કરી દે. In that case, you will not get the chest rise. Even after doing that, patient is not improving. The third step is S. S means, P means pressure increase. Routinely what we advise, 1 kilo નું બચ્ચું હોય, use 1 finger and 1 thumb. 2 માં 2 finger and thumb for pressing the bag. જો excess pressure આપો તો pneumothorax થઈ જાય. So we don't want, but in this scenario you can have little increase in the pressure. Last is alternative airway, that is intubation. Okay, just remember this flow. How will we are asking you what are the signs of effective PPV. જેવું effective PPV જશે બચ્ચાનો color will improve, બચ્ચું pink થવા લાગશે. The heart rate will increase. You can hear the breath sounds and you can see the proper chest movements. 1 મિનિટમાં કેટલા બ્રેથ્સ આપવાના પૂછીએ છે. ટ્રાય એન્ડ મગ અપ ધીસ 40 to 60 બ્રેથ્સ પર મિનિટ. ખાલી પીપીવી આપીએ છીએ, ધ ફ્રીક્વન્સી ઇઝ 40 to 60 બ્રેથ્સ પર મિનિટ. પ્લીઝ મગ અપ ધીસ નંબર. દર વખતે ઘડિયાળ જોઈશું, જો ચેસ્ટ રાઇઝ કોણ જોશે બચ્ચાની? ધેટ્સ વાય દેર ઇઝ આ ગાવાનું છે. ઓકે, બ્રેથ 2 3, બ્રેથ 2 3, બ્રેથ 2 3. Breath means we are giving a compression of the back. 2 3 is we are allowing and recoiling the coming back to the original position of the back. હાથમાંથી છોડવાનું નથી. So breath is compression, 2 3 is a release. 30 seconds of PPV is done. Now there could be 3 scenario. બચ્ચું સરસ ઇમ્પ્રૂવ થઈ ગયું, more than 100 થઈ ગયા. બંધ કરી શકાય કે? સી વી ઓલવેઝ ગીવ યુ ધ સિનેરિયો, સો યુ શુડ બી વિથ મી ઇન ધ ફ્લો ચાર્ટ. સપોઝ યુ હેવ સ્ટાર્ટેડ પીપીવી, એક્ઝામિનર કહેશે કે હાર્ટ રેટ ઇઝ 140, તો શું કરશો? યુ હેવ ટુ હેવ અ લુક ફોર ધ બ્રીધિંગ એફર્ટ્સ. બચ્ચાના બ્રીધિંગ એફર્ટ્સ ના હોય, દેન યુ કેન નોટ સ્ટોપ પીપીવી. બી ક્લિયર. સો હાર્ટ રેટ મોર દેન 100 વિથ ગુડ બ્રીધિંગ એફર્ટ્સ. Then and then slowly taper and stop the PPV. Be clear, 2 things. Heart rate more than 100, good breathing efforts. Then and then you can stop. The second scenario is heart rate is more than 60. બે જ આંકડા કયા હતા, 60 and 100. Between 60 to 100, continue the same. Less than 60, continue PPV but start chest compression. Clear? Less than 60, start chest compression. Just for your knowledge, nowadays all the algorithm is based on the SpO2. No need to remember this. But in few scenario we ask you, baby is having good breathing, but the baby is having persistent cyanosis. Your answer should be, we have to give supplemental oxygen. Starting with FiO2 30. Just remember one line, nothing else. We always ask you, we offer you the ET tube. બધાને ઓળખાઈ જશે ને? After identification, the important thing is indication of endotracheal intubation as per the NRP. બે ક્વેશ્ચન આપો એટલે કેસના એટલા માર્ક પૂરા મળી જશે. સો ટ્રાય ટુ રિમેમ્બર ધીસ. સો વેન યુ હેવ પ્રોલોંગ પીપીવી, ઇટ ઇઝ ગુડ ટુ હેવ ઇન્ટુબેટેડ બેબી. એટલે પહેલું શું આવશે? પ્રોલોંગ પીપીવી. સેકન્ડ થિંગ, એમઆર સોપામાં હતું ને છેલ્લે એ. સો એઝ અ એડવાન્સ એરવે વેર યુ આર નોટ હેવિંગ પ્રોપર ચેસ્ટ રાઇઝ, યુ કેન ગો ફોર ઇન્ટુબેશન. ક્લિયર? થર્ડ, when you decide to start chest compression, that is a point where you can intubate for better coordination. Fourth, when you want to give some medication like adrenaline, you can give through ET. એક્ઝામમાં પૂછતા હોય છે કઈ દવા આપી શકાય. ટ્રાય એટલીસ્ટ ગીવ વન આન્સર એડ્રેનાલિન, સેકન્ડ ઇઝ સર્ફેક્ટન્ટ. બહુ બધી છે, બટ એટલીસ્ટ ધીસ ઇઝ ટુ મસ્ટ ટુ નો. પછી આ પૂછીએ છે કે હાઉ ટુ ચૂઝ અ સાઇઝ. 3 આંકડા છે, ગોખી કાઢજો, એમાં કોઈ ટ્રીક નથી. એન્ડ હાઉ મચ લેન્થ ટુ ઇન્સર્ટ NTL tragus to this plus 1 centimeter. That is a formula. See, basically advanced NRP is a full day course, but I am trying to revise in a short time. So please do not disturb in between. Okay? Now chest compression, we always ask you the indications. So here again it is a full indication. Heart rate less than 60 even after providing 30 seconds of positive pressure ventilation. Clear? Heart rate less than 60 even after providing 30 seconds of positive pressure ventilation is indication of chest compression. Technique, Mannequin upar we always ask you to locate the area. So nipple line, that is a upper line. Xiphi sternum માં જે નીચેનો pointed part છે, that is a lower. So that will be your approximated lower 1/3 of your sternum. That is the area where you will start chest compression. These all are the important questions. Please remember how much to compress. Exam માં stress માં બહુ બધું compression થઈ જાય છે. Stress લેવાની જરૂર નથી. Just compress that 1/3 of your AP diameter, not more than that. Rate. હવે છે ને બોલવાનું કહેતા હોય છે અમે કે by which mean you will calculate કે કેટલા chest compression ગયા, કેટલા breaths. So try to remember 1 end, 2 end, 3 end, breath end. Clear? So when we say 1, that is a compression. When we say end, we allow chest to come back. 2, second compression, end is allowing come back. 3 is third compression, end is coming back. Another person will speak breathe end. So breathe is compression of bag, Ambu bag, end is allowing back, come back to the normal position. So in 1 minute, how many events will be there? That will be total 120. Clear? These all are the questions. કે 1 minute માં કેટલી event થશે? 120. Out of which 90 will be chest compression, 30 will be the breaths. So ratio will be 3:1. After 1 minute you have to check the heart rate. Cardio is a mnemonic to યાદ જે આપણે રાખવું હોય ને દરેક વસ્તુમાં ગોખવાનું. કાર્ડિયો મીન્સ ઇફેક્ટિવ ચેસ્ટ કમ્પ્રેશનના પોઈન્ટ્સ છે. પીક લઈ લો, વોટ આઈ હેવ ટોલ્ડ ઇઝ ધ સેમ. નાઉ મોસ્ટ ઇમ્પોર્ટન્ટ પાર્ટ ઇઝ વેન યુ સ્ટાર્ટ ચેસ્ટ કમ્પ્રેશન યુ હેવ ટુ સ્ટાર્ટ FiO2 100. અત્યાર સુધી વી આર ડુઈંગ વિથ ધ રૂમ એર. નાઉ વી હેવ ટુ સ્ટાર્ટ વિથ ધ FiO2 100. વેન ટુ સ્ટોપ? So heart rate more than 60, you have to stop the chest compression, continue the PPV. And heart rate more than 100, stop PPV. Medication ma only 2 medications we use in NRP. One is adrenaline, second is normal saline, nothing else. Okay? બધાના છે ને indications ખબર હોવા જોઈએ, dose and route. So બધાને પૂછીએ છે ને એડ્રીનાલિન પકડાઈ દઈએ. So the concentration of the adrenaline in that ampule will be 1:1000. We need to dilute into the 1:10,000. એટલે શું બોલવાનું? I will take 1 ml of adrenaline, will dilute with 9 ml of NS. That is known as the stock solution. Please remember, જે તમને પકડાયું હશે ને vial or ampule, whatever, the concentration will be 1:1000. That we will make to 1:10,000. Dose fixed છે. IV માં dose is ગોખી કાઢો 0.2 ml per kg. જે બનાવ્યું ને આપણે સોલ્યુશન એનું 0.2 ml per kg is IV dose. You can repeat every 3 minutes. Maximum 3 doses. Please remember this 3 point. Dose, you can repeat every 3 minutes, 3 dose. The volume will be like 0.6 ml. 2 કિલોનું બચ્ચું હોય તો it will be like 0.6 ml. એટલું તો છે ને સિરિંજમાં જ રહી જાય. So it is always followed by 3 ml of normal saline push. આટલું બોલી દેજો. You can give adrenaline through ET route. એનો ડોઝ છે ને it is high. That is 1 ml per kg. IV નો હતો 0.2 ml per kg. For endotracheal route it is 1 ml per kg. એમાં એવું છે you have to give some puffs of PPV. બેકથી થોડું પ્રેશર આપવાનું, then it will get sprayed into your lungs. This is just to remember, જ્યારે બચ્ચું not improving with adrenaline હોય, we can consider normal saline push. Just remember, no need to mug up. You can give normal saline push at 10 ml per kg over 20 minutes. Preterm માં be gentle, ખાલી પૂછીએ તો, otherwise just keep these 2 points in mind. You can use plastic bags, avoid head low position જે પહેલા કીધું હતું ને, otherwise ICH intracranial hemorrhage can happen. CPAPs we can offer, surfactants we can offer. Gentle handling please. Thank you. Now I hand over to Dr. Charul for further.
Presentation. ક્યાં છે?
શોધવું પડશે. આ છે ને ચારુલ મહેતા લખ્યું છે ને, એ જ છે ને?
હા, તો સીવી છે અને લેક્ચર તો મનજીતભાઈના મોબાઈલમાં આપેલું.
મંજીતે લોડ કર્યું હશે, પૂછો અને બહાર નીકળી છે પેલા ભાઈ મને કહી ગયા હતા ક્યાં છે બતા
જો તો. Good afternoon. All those who want to leave can leave just now. પછી ચાલુ લેક્ચરમાં મજા નહીં આવે એટલે. હા, કંઈ વાંધો નહીં. ઓકે, સો yes. So sir want to announce something.
મંજીતભાઈ. Now I request Dr. Maulik Seth sir to felicitate Dr. Dhara Goswami madam.
તમે લોડ કર્યું છે? લોડ કર્યું છે મારું લેક્ચર?
શું થયું?
લેક્ચર તમને પીપીટી આપ્યું હતું એ?
બે મિનિટ.
હા.
શું કહેવાય બોલ.
આ તો ખાલી સીવીની સ્લાઇડ છે. તમને આપી દઉં?
આયા બોલા.
હા.
એક મિનિટ.
તમારે થઈ ગયું અનાઉન્સમેન્ટ?
There is one small announcement. After this last practical revision session, there is a arrangement for high tea outside.
Your attention please. Yes.
એક બીજું બી એનાઉન્સમેન્ટ છે કે આજનું અને ઇવન આપણા બધા નેક્સ્ટ બધા રિવિઝન આપણે અમદાવાદ મેડિકલ એસોસિએશનની યુટ્યુબ ચેનલ છે એની ઉપર બધા જ આપણા આ જે રિવિઝન ક્લાસીસ છે આપણે લાઈવ રાખ્યા છે અને વિડીયો રહેશે. એટલે અત્યારે તમારા કોઈ પોઈન્ટ મિસિંગ રહ્યા હોય તો ઘરે જઈને આના આ લેક્ચર તમે ફરી જોઈ શકશો. એટલે આ વર્ષે અમે આ સ્પેશિયલ અરેન્જમેન્ટ કરી છે મેડમ. રાઈટ.
I really appreciate the efforts taken by AMA, our own family over here, and how they are taking care of you all the budding doctors of the society. So, a big round of applause for our office bearers and their efforts. Thank you so much. I thank you for giving this opportunity to address the crowd. Okay, so before we begin, let us have a relaxation exercise because the 1 hour now will be a pictorial journey by and large. Okay, all those who want to leave can leave because YouTube live is still live. So now they will sit in the comfort of house and attend from home. Okay, so all those who are sitting, let us now do a small exercise. Stretch your arms. કરો, કોઈ રિલેક્સ નથી થયું લાગતું. So relaxation is very important before you again begin with a pictorial journey, right? Okay. So these are the learning objectives. I think the crowd should settle down now. હવે બોલું? Everything settled? Okay. So you have to recognize that a baby's history begins long before the birth. You have to master systemic head to toe physical examination and distinguish between normal newborn, the normal variation, and what are the clinical red flags, right? So these are the main learning objectives. Essential newborn care and resuscitation, these are the core competencies according to our NMC guidelines of CBME. This is the high risk and low birth weight babies. These are the grouping of all the competencies where you have to identify these. Neonatal jaundice and metabolic issues, congenital anomalies and birth injuries. Okay, so to begin with, we will begin the history with basic details like baby of, we will name of the mother, right? Age, sex, race, address, date of birth, time of birth, and what is the corrected gestational age. Maternal details are very important because that will reflect what your baby will be having in future. So maternal age, active married life, obstetric history, GP, LA, LMP, EDD, mother's blood group, maternal illness before and during pregnancy, maternal medications, type, dose, risk of teratogenicity and risk of IUGR. So certain history is very important. Antenatal history, we have to take not this much in detail, but if the mother has passed through certain changes in first trimester, second or third trimester, then this history is very important. How many antenatal visits she has taken, whether she has taken TD or TDAP. Okay, so now the government has changed TT to TD. So that is the latest change. So remember this, now anywhere we are not speaking TT. So everywhere TT is there, it has been replaced with small dt or TD. Weight gain in the pregnancy. So this all has implication on the newborn. Okay. Natal history, stages and duration of labor, spontaneous or induced, vertex or breech, the liquor color, meconium stained or not, what is the gestational age, term or preterm, what is the mode of delivery, whether it is normal vaginal delivery, assisted vaginal or instrumental in form of C-section, what is the indication of C-section, whether the baby has been delivered at home. We still get, few percentage of baby who are delivered at home. Majority of babies are now institutional deliver. So this history is also very important, and who has conducted the delivery if it has occurred at home. So whether it was occurred by trained birth attendant or DI or some local person is very important history. Whether the baby has cried immediately or not. Resuscitative measures, as Dr. Dhara madam has taught you NRP. So elaborately, how many measures have been taken into consideration till PPV up to chest compression. That will give you a picture that baby has not cried for at least 30 seconds, for up to 60 seconds. So how much impact the hypoxia has caused to the brain or the other organs of the body can be taken into account. And whether the DCC has been practiced or not. What is the full form of DCC? That was the old full form. Delayed is now been replaced by deferred. Right? So we say it is deferred cord clamping. It is not delayed cord clamping. Right? And it has to be at least 60 seconds or 1 minute. It can be beyond 1 minute by 1 to 3 minutes. But at least 1 minute to હોવું જોઈએ. Okay. Postnatal history, whether there is initiation of early skin to skin contact uninterrupted for 1 hour. Remember this thing. The moment baby is delivered, baby should be placed on the mother's abdomen. In normal vaginal delivery, I am telling about, right? In C-section, as madam has told, we can put on mother's chest, but we have to take care of the aseptic precaution. So at least in normal vaginal delivery, baby has to be placed on the mother's abdomen. What is the time of initiation of breastfeeding, whether it was started just at the birth, right? And what is the frequency and timing? What is the birth weight? It is important to record the footprint of the baby for documentation purpose, for handing over to the relatives in case of, recording gender is very important because to avoid swapping of the baby. It is very, in Bollywood movies, they may see कि एक का बच्चा दूसरे के पास चला गया. But in real scenario, it is a medico-legal issue. So this is very important thing which has to be documented. Hepatitis B birth dose and BCG has been given. Vitamin K1 injection has been given. And what is the timing of first urine and meconium? So this is just overall briefing of the postnatal history. Neonatal history, again, most of the newborn which you will get in your exam will be normal newborn, or at the most babies who have some jaundice and they have received some phototherapy, or they are admitted for some minor illness, like, so you will be not getting any sick baby in your exam, remember this. But you can be asked question, how will you identify a normal newborn from a sick baby? So that we will see later. In neonatal history, if any complications are there, detailed history including negative history should be mentioned, just like in your routine history taking. Any history of hyperbilirubinemia, seizures, cyanosis, or any other complications. Activity and feeding pattern should be noted. Details of treatment given to the baby, whether the child was at mother's side in the postnatal ward or under the NICU care where the child was admitted. Treatment given to the baby, duration of hospital stay, and discharge summary or details. Diet or feeding history. Remember all these definitions, આ બધા બહુ common questions છે અને where people commonly err is exclusive breastfeeding. Every time this question is asked, what is the definition of exclusive breastfeeding? And every time the candidate bluffs. So definition is in standard words and it is available in textbook. For the want of time, I have not written everything. You have to read all these definitions. What is exclusive breastfeeding, partial breastfeeding, predominant breastfeeding, token breastfeeding, optimal breastfeeding, feeding in demand. Okay? Supplemental feeds or any prelactals has been given or not. Number of times the mother feeds the baby. There is a number of the times urine passed by the baby. How long after each feed the baby is sleeping. And whether there is any regurgitation or positing. Family history, you have to draw the pedigree by 3 generations. If you find some genetic or congenital cause, consanguinity, as sir has told, Snehal sir. Family history of any chromosomal disorder, genetic cause or splenectomy, any surgery in the family member, hearing loss. So these are all very relevant history if you have a baby with some orofacial malformation or some congenital ear abnormality. Immunization history, BCG, OPV, 0 dose and Hep B, birth dose. Why do we say OPV 0 dose and up to what time we can give this 0 dose? Up to first 2 weeks, right? And hepatitis B birth dose. After that we give 3 doses more, right? So reason for this is also asked. If you are performing very well, this question may be asked, why 0 dose has been introduced by the government of India? Because so far we were giving with 3 pentavalent doses, right? So now what has happened that at birth we are capturing the baby and giving Hep B 0 dose, meant birth dose. Socioeconomic history, modified Kuppu-Swamy classification. Okay. So coming to examination, general statement regarding the baby's state of wakefulness, we will see later. Vitals, as Dara madam has told, TA, BCD. So everywhere when newborn come, you have to remember this thing. TA, BCD. CRT, capillary refill time. How will you count capillary refill time? This is the most commonly asked question to demonstrate. કેવી રીતે કરશો? Anyone? we will blanch the baby's sternum using either thumb or first finger, right? We will count 5 seconds. કેવી રીતે કાઉન્ટ કરવાના? 1001, 1002, 1003, 1004, 1005. We will lift our finger and we will continue counting 1006, 1007, 1008. So by that 1008, that is a 3 second more after our pressing. If the blanching disappears, that means the CRT is normal. Okay? Anthropometry, weight, length, head circumference and chest circumference is very important. General examination, again IPCOL, gestational age assessment by modified Ballard score. Okay, head to toe, you have to see for skull, size, shape, suture, AF, PF, any other swelling, whether caput or cephalometoma, eyes, any discharge, abnormality. It is important to document red reflex. Why? Because cataract and retinoblastoma are two things which you can detect bedside using torch, right? So if this absence of red reflex, you have to raise your antenna. Ears, whether they are low set or abnormal. Bilateral choanal patency, you have to see in the nose, oral cavity, any abnormality, cleft lip, palate, natal teeth, oral thrush, neck swelling or webbing, skin, icterus, you have to see Kramer's rule, milia, Mongolian. So these are a certain physiological stigmata that we will see later in a pictorial journey. You have to see for the umbilicus. Okay, tell me one abnormality if you have not seen at birth, you will not find it lifelong. You will miss it lifelong. What is that? બર્થ વખતે જોવાનું મિસ કર્યું તો લાઈફ લોંગ જોઈ નહીં શકો. So that is single umbilical artery, right? So only if you can see the examine the stump, then only you can identify the umbilical artery is single. We encounter many patients in our institute. Okay, genitalia, descended, undescended urethra. So these all important parameters are very crucial in your physical examination for differentiating between term and preterm babies also. So you read textbook, what are the differences between a term and preterm baby and how can you identify just by physical examination. Hips, you have to check for dysplasia of the hips. Femoral pulses, it is important to document femoral pulses because once you palpate the femoral pulses at birth, it by and large rules out coarctation of aorta. So these are all things which are very important for documentation purpose. Arms and legs, if there are any shortening of fingers or dermatoglyphics, bone and spine for neural tube defect. Okay, systemic examination, CNS, basically if a baby is asphyxiated, the neurology would be affected by, say brain is the organ which is affected in that, but also kidney, lungs and heart is also equally affected. Okay, so the state of baby is taken into account. So these are the stages of wakefulness. There are 5 stages. Stage 1 is when the baby keeps eye closed, regular respiration, there is no movement. It is also known as quiet sleep or non-REM sleep. Stage 2 is baby is having eye closed, irregular respiration, no gross movement, and it is known as REM sleep. Stage 3 is eyes are open, no gross movement and quiet alert. I can see certain students who are in this quiet alert state. એકદમ સ્ટીલ થઈને જોઈ રહ્યા છે. Some are having non-REM, some are having REM. So different crowd is there here. And okay, then stage 4 is eyes open, gross movement, no crying and active alert. And people having stage 5 have left this audience. So they were very fidgety. કે અમને તો YouTube live પર બી જોવા મળે છે તો why to listen here? So they have left. Okay, so these are 5 stages. Why it is important to know these stages? Because it is in the stage 3 and 4 you can examine the neonatal reflexes. In rest all the stages you will not get the appropriate response. Okay, so these are the common reflexes. લગભગ આની આજુબાજુથી પૂછતા હોઈએ છે. We are not going to ask you those 52, 72 reflexes which we ask in our PG. ઓકે, પીજી એક્ઝામમાં અમે વધારે ડિટેલમાં પૂછીએ, but these are the common and undergraduate should know. Sucking, rooting, swallowing or cardinal 4-point reflexes. Moro's reflex, you should know what is a normal Moro's response, asymmetric Moro, incomplete, exaggerated and reverse Moro. Okay. ASTNR, asymmetrical tonic neck reflex, crossed extensor, glabellar tap and grasp reflexes. So these are very common reflexes. You should know when they start, when they are complete and when they disappear. Simple. Any standard textbook has given all these things. So refer your textbook. Okay, respiratory system, you have to see what is the pattern of breathing, respiratory distress or breath sounds, whether there is grunting, as Sir has told. Grunting in newborn will signify what? So if it is a full-term child, that grunting would suggest parenchymal involvement in form of pneumonia. But if it is a preterm child, that grunting would suggest what? RDS, right? Okay. Cardiovascular system, peripheral pulses, cardiac murmurs, abdomen, hernia and organomegaly. Okay, so immediate care of the newborn. So there is a concept of first golden minute which madam has told, right? There is also another concept of first golden hour. 1 કલાક. બરાબર? ફર્સ્ટ 10 મિનિટ્સના બેબીને રિસસિટેટ કરીને સ્ટેબિલાઇઝ કરવાનું. નેક્સ્ટ 10 to 30 minutes you have to take care of the baby for the transport, and next 30 minutes you have to stabilize the baby. So this is the concept of first golden hour also. Okay, so this is your core competency. Explain the care of a normal neonate. આ પૂછાય છે. Immediate care includes clear airway, established respiration, maintenance of body temperature, protection from hemorrhage and identification. ધરા મેડમે બહુ જ બધા ક્લિનિકલ પોઇન્ટર્સ તમને કહ્યા છે કે how you will take care of the baby during resuscitation, right? So this is very important slide. તમે આટલું વાંચીને જશો ને તો તમારા મેજોરિટી વાઇવામાં આ જ બધી વસ્તુ પૂછાશે. Essential newborn care. Immediate care at birth, deferred cord clamping, thorough drying, assessment of breathing, skin to skin contact, early initiation of breastfeeding. Next comes thermal care, resuscitation when needed, support for breast milk feeding, nurturing care, infection prevention and assessment of health problem, recognition on response for danger signs and timely and safely referring the baby, right? So these are 5 pillars of neonatal care. Okay. Thermal care, again this is your competency. Discuss the temperature regulation in newborn, clinical feature and neonatal hypothermia. હવે આ થિયોરીનો ક્વેશ્ચન તમને પૂછી શકે, પણ તમને એક્ઝામમાં એવી રીતે જ પૂછે, how will you grade hypothermia, right? So what is cold stress, mild, moderate, severe, what is significant hypothermia? That is a new terminology in the facility based newborn care guideline. Significant hypothermia, you read that. Okay, so warm chain, what are the components of warm chain? આ પૂછાઈ શકે. Okay, so these 10 components you have to mug up and remember, and it should come like a that rifle કયું હતું યશના મૂવીનું, યશનું મૂવી હતું ને KGF ચેપ્ટર 2 નું કયું હતું પેલું રાઇફલ, સમથિંગ. સો ઇટ શુડ કમ લાઈક ધીસ. આ 10માં બ્લફ નહીં કરવાનું, બરાબર? સો ધીસ વોર્મ ચેન ઇઝ વેરી ઇમ્પોર્ટન્ટ. This is the same warm chain. So newborn health rotates behind that. Okay. 4 mechanism of heat loss, a quick revision. Evaporation, radiation, convection, conduction. Right? So remember these. How will you explain it? Okay. One important thing which we discuss with our PGs also, that out of all these 4 mechanisms, we use 3 mechanisms to restore the thermal care. Which are these 3? કયું use નથી થતું? Evaporation. So evaporation is the only mechanism where the baby will lose the heat but will not regain the heat. But rest all like conduction, convection and radiation. We will use all three to even regain the heat. બરાબર ને? તો conduction is when that comes in contact with the colder. તો કોલ્ડર સરફેસ સાથે કોન્ટેક્ટ આવે તો હીટ લૂઝ થાય, તો વોર્મ સાથે આવે તો હીટ મળે ને. ઓકે, સો રિમેમ્બર ધીસ થિંગ. કન્વેક્શન ઇઝ વોટ? ડ્રાફ્ટ ઓફ એર. સો ધ મોમેન્ટ પવનની લહેરખી આમ જાય, ઠંડા પવનની લહેરખી હોય તો ધ્રુજારી થઈ જાય, પણ સાથે જો ગરમ પવન આવતો હોય તો બેબી વિલ અગેન રિસ્ટોર ધ હીટ. એન્ડ થર્ડ ઇઝ radiation. I mean, some fonts are not visible here, but this is radiation. So if the distant objects, they are cold, right? Then baby will lose the heat. તમને દેખાશે નહીં આ, એ radiation થી lose heat થશે. But if these walls are wooden, they will not have any coldness, right? So baby will not lose the heat. હવે આ જ વસ્તુ તમે એલઆરમાં કે ઓટીમાં જાઓ તો એમાં તો વુડન વોલ ના હોય ને, તો હાઉ વિલ યુ રિસ્ટોર દેટ? સો બાય રિસીવિંગ ધ બેબી ઇન અ વોર્મ ડ્રાય લિનન, નંબર 1. નંબર 2, ઇફ એનઆરપી ઇઝ રિક્વાયર્ડ એઝ મેડમ હેઝ ટોલ્ડ કે ઇમિજિએટ કોર્ડ ક્લેમ્પ કટ કરીને લેવાનું છે બેબીને, તો યુ વિલ રિસીવ બેબી અંડર ધ ન્યૂબોર્ન કેર કોર્નરમાં રેડિયન્ટ વોર્મર વિચ ઇઝ પ્રી વોર્મ્ડ. ઓકે, સો દેટ વે યુ કેન મિનિમાઇઝ heat loss. So this is the same in pictorial form. Okay, general management of hypothermia બહુ important છે. You have to remember this. Quickly baby ને we will avoid quick warming gradual કરવાનું છે, પણ drying immediate જ કરવાનું છે. If baby is lying in the urine, so remove that wet soaked diaper and immediately keep in a clean dry cloth. Okay. If a baby is in incubator, increase the incubator temperature, avoid exposure to direct source of air draft, check RBS. Hypoglycemia and hypothermia are just like Jay and Viru. કયા મૂવીમાં આવે જય અને વીરુ? શોલે. So they are inseparable friends. So whenever there is hypothermia, always check for hypoglycemia, and whenever there is hypoglycemia, look for the cause for hypoglycemia, whether hypothermia is not there. Okay. Check frequent body temperature and give antibiotic if infection is suspected. Okay, so normal newborn. Okay, we all know it is 0 to 28 days. This is your core competency, assessment of a normal newborn. To assess the newborn's immediate adjustment to extrauterine life, concept of first golden minute. So these are two competencies which are related to birth asphyxia, and performing neonatal resuscitation in a mannequin is not a core it is a core competency, but in your logbook, in the internship, you have to pass that core competency. How many resuscitation you have observed, how many you have assisted, and how many you have done independently, right? So that is one core competency our NMC has mandated for IMG. Okay, transitional assessment. These are a period of reactivity. Stage 1 for first 30 minutes. Remember this. Baby is very active after birth for first 30 minutes. Ready, receptive to take first feed. Receptive for everything, all stimulus baby wants to need. કોઈને breast crawl ખબર છે? Have you ever heard about this word terminology? આ તમને વાઇવામાં પૂછાઈ શકે. What is breast crawl? સાંભળ્યું છે? You can YouTube it or Google it. Breast crawl was observed at Nandurbar district in Maharashtra, and baby was put on the mother's abdomen. The baby crawled from the abdomen up to the mother's breast, searched for nipple and attached to the nipple on its own. So this video is available on YouTube. You can Google it also. So it is very important, breast crawl, that all the other animal babies, they are not taught to put on breast. They search for their feed on their own. ખાલી હ્યુમનના બેબીને જ આપણે કરવું પડે છે, right? Stage 2 is last about 2 to 4 hours. Again, during this period, the baby is in state of sleep and calm. And then there is a second period of reactivity for about 2 to 5 hours where baby is responsive. And followed this stage, baby will go into a deep sleep. Okay, this is meconium. Sometimes I feel being in round, no? I have to ask, okay, what is the color of the stool? What is the color of the urine? So you feel like a sanitary inspector rather than a pediatrician. But it is very important whether the baby has passed the stool or urine or not, and whether the passage of meconium has occurred timely or not. So what is the time limit for passage of meconium? First 24 hours. And what is the time limit for urine? First 48 hours. Learned audience છે આમને તો એક્ઝામની ક્યાં ટેન્શન છે? They know everything. Okay. So vital signs, growth measurement, general appearance, posture of the baby. See, you have to check the head circumference with these method. It should be overlapping, flexible tape, and two prominent points, occiput and your above the glabella, right? Suprapalpable, this brow. So these two landmarks are very important and it should be overlapping. And remember, it is in centimeter. ઘણા છોકરાઓ પેનિક કરીને શું કરે ખબર છે? ઇંચમાં બોલે. પછી અમારે પૂછવાનું કે ટેપની બીજી સાઈડ શું છે? તો સેન્ટીમીટર. પછી they will convert into centimeter and say. તો remember this. Normal parameters જોઈ લેજો. This is a normal posture of a full-term baby. Flexed, all four limbs. Skin, you have to see whether it is good, uniformly pink, baby pink color. This is how a baby will look. So this is acrocyanosis. આટલી ઠંડી હોય ને તો હાથ પગ ભૂરા પડી જાય. That is acrocyanosis. So here, for assessing actually hypoxia, then you have to refer what Dhara madam told, target saturation values. બરાબર? Up to first 10 minutes માં target saturation સાથે match કરીને oxygen આપવાનું. Don't overgive oxygen, because remember, oxygen is also a drug. Okay, so a fast pictorial journey of physiological stigmata. Vernix, you have to keep it intact. પહેલા એક when we were resident, it was a concept કે sister will bring oil અને oil થી આખું baby sweet oil કહેતા હતા એને. I don't know why they were telling it as a sweet oil, but the labor room sister would keep cans and cans of sweet oil. They will soak the gauze with the oil and clean the entire vernix. But the now concept has changed. You have to preserve vernix because it will preserve the heat of the baby. It will not precipitate hypothermia. It will prevent hypothermia. So this is how the vernix will look. Look at the axilla. દેખાય છે? Cheesy material. I am sure you will now not eat cheese. It will remember you vernix. Okay, lanugo hair. So the more premature baby is, the heavier the presence of lanugo is. So this picture is not very good, but it's okay. You can see the lanugo over the shoulder and back of the baby. Mongolian spots, black discoloration. You can see like this. દેખાય છે ને? Blackish greenish spot on the buttocks and the lower back. આમાં વધારે clear છે, right? Here. Okay, desquamation. So the more mature a baby is, the more desquamation of the skin may occur, right? So skin is by virtue of gestational age, it will have different kind of texture. So in a preterm or very preterm, it may be gelatin type or very fragile. But as the baby matures, the layers of skin will be maturing, and more and more mature baby will have a mature skin with even desquamation. એટલે peeling, skin peeling આપણે થતી જોઈએ ને, તો cracking of the skin and all, that will be seen. Okay, milia. Milia જોયા છે કોઈએ? Okay. So these are white spots you can see. Sometimes neonatal acne is also seen. Okay, physiological jaundice. This is also one core competency. Etiology, clinical feature and management of neonatal hyperbile. So you can see the skin. Okay, Kramer's law is very easy to remember. Okay, which are the points you have to use? So these areas are given 1, 2, 3, 4, 5, right? And again, same way, while you are checking CRT, you are blanching the skin. So once you blanch the skin and you lift your finger, you will see either paleness or yellowness. So that way you will differentiate. I will not go in detail with this. Okay, in head you have to look for anterior fontanelle and posterior fontanelle. Okay, caput and cephalematoma. This is the important. Listen, આ difference બહુ જ પૂછાય છે. How will you differentiate between caput succedaneum and cephalematoma? Okay, so here you can see this caput succedaneum and this is cephalematoma. So this is suture line in between the arrow. So cephalematoma will not cross the suture line. Okay, while caput succedaneum will cross the suture line. It is boggy and fluctuant, while cephalematoma is more firmer. Caput will disappear in 2 to 3 days, while cephalematoma may last long for 2 to 3 or even 4 weeks beyond. Okay, cephalematoma patients are at risk of exaggerated physiological or even pathological hyperbilirubinemia. Okay, so these are all few key differences between both. So this is how the caput will look. It is blanchable. Cephalematoma never crosses suture line, not blanchable and firmer. See, you can see on the high parietal area on the left side. So this is cephalematoma. Okay, eyes. These are eyes of normal newborn. You can see some eyelid edema, disconjugate eye movements, subconjunctival hemorrhage. It is a physiological stigmata. You have to just reassure the parents, it will disappear. Okay? Congenital glaucoma, cataract. Just remember few conditions where you can find congenital cataract. So if this question comes up, you may be asked what are the conditions associated with this. Ears, startle, look for cartilage. These are all differentiating features for a term and preterm baby also. Preauricular tag, it may be associated with some renal condition or other syndromes. Nasal patency, normal nose, dislocated nasal septum, mouth and throat, neck. Okay, so you may see if there is some webbing of the neck. Again, systemic examination. So these are Epstein pearls, a pearlish white on the hard palate. You can see spots on the hard palate. Hardly તમારા exam વખતે 3 મિનિટમાં બેબી ક્રાય કરશે ને તમને જોવા મળશે. But you may be asked to list what are the physiological stigmata you have seen during your postnatal posting. So you can list this. અને આ બોલવું સૌથી ઈઝી છે કારણ કે આ તમને બતાવવાનું કહેશે નહીં. Okay? Identify birth defect. This is also core competency. How you can identify tracheoesophageal fistula, esophageal atresia, anal atresia, cleft lip palate, diaphragmatic hernia and acute abdomen. So this is cleft palate. Baby is having isolated cleft palate, cleft lip. Okay, cheeks, normal tongue, and here you are seeing ankyloglossia. You can see this frenulum is attached. Ankyloglossia again, gums, natal teeth. Sometimes you can just see the elevation on the gums, right? The teeth are not actually erupted. But in some babies, you can see a single teeth like this, tooth, and then can be multiple teeth also. Nothing to do if they are not loose, they are to be managed in a same way. એને કશું extraction નથી કરવાનું હતું. If it is loosely lying, then it should be referred to a dentist and they can be removed because it may interrupt in breastfeeding. Abdomen, so it is usually cylindrical in shape. If it is scaphoid, then it is in which condition? Diaphragmatic hernia. Okay, umbilical cord, bluish white with 2 arteries and 1 vein. Single umbilical artery is associated with syndromes, renal anomalies. Meconium stained cord, circulatory system, respiratory system. Okay, urinary system, first 48 hours. These are difference between female genitalia, male genitalia, and okay, you may find sometimes gynecomastia. So these are certain questions they may be encountered during postnatal period, that if baby's breast is enlarged, there is gynecomastia, how will you manage? So nothing doing, it is under the maternal hormonal influence and they will eventually resolve. Okay, sometimes you may say that a female is having withdrawal bleeding. So that is also termed as withdrawal bleeding in a female neonate is termed as, oh, I thought you are knowing that, is pseudomensis. It is again under the influence of maternal hormone, and as the circulating hormone in the baby, the maternal hormones which are entered the baby's circulation, the once they are metabolized or they are cleared of the blood, this bleeding will stop. Okay, CNS, again we have discussed this. Morose, just read the methodology, how to elicit the reflexes. You will not be asked to elicit, but you will just ask the method. Extremities, okay. Club foot, it is important to identify certain birth defect at the birth. Under RBSK program, RBSK નું full form શું છે? જાગી ગયા બધા. Read all the programs related to newborn care health given by GOI, all the national health program. તમને કોઈ બી પૂછાઈ શકે છે. What is INEP? India Newborn Action Plan. Okay. So care of newborn in postnatal ward. Again, a quick review, steps of normal newborn care. This is the competency, identify and stratify risk in a sick neonate using IMNCI guideline. IMNCI નું full form શું છે? આ નથી આવડતું, એક્ઝામમાં બધા ચૂપ થઈ જાય છે. ન્યૂબોર્નમાં N stands for newborn, એ બી નથી બોલી શકતા. So remember this thing, integrated management of neonatal and childhood illnesses. Okay, standard precautions. Okay, can anyone show me steps of hand hygiene? You gentlemen, steps of hand hygiene. First prerequisite is what? Remove your ornaments, watch and everything. એટલે એક્ઝામમાં વોચ પહેરીને ગયા હોય હાર્ટ રેટ કાઉન્ટ કરવા માટે, તો યાદ રાખીને આ કરવાનું. બરાબર? રિમૂવ ફોર ગર્લ્સ હુ આર વેરિંગ રિંગ્સ એન્ડ લકી એન્ડ એવરીથિંગ, રિમૂવ ધેટ. ઓકે, ફર્સ્ટ ઇઝ palm to palm, that is सीधा. So there is a mnemonic for that, Suiman, SUIMAN. So सीधा, you can show them. सीधा, ulta, interlock, interlock, interlock. આગળ, હા, interlock. મુઠ્ઠી, અંગૂઠા એન્ડ નાખૂન. યાદ રાખજો છોકરાઓ, લાજ રાખજો. So what are the 5 cleans, 7 cleans, 8 cleans? હવે વધતું જ જાય છે એ બધા cleans, all clean practices, remember that. Prevention and management of hypothermia, this we have already done and dusted. Early skin to skin contact, નવજાત શિશુ સુરક્ષા કાર્યક્રમ, what madam has very beautifully described the entire NRP. NRP અમે લોકો 8 થી 6, મેડમે તો આખો દિવસ કીધું, પણ as a trainer we start a day before that, અને અમે 8 થી સાંજે 6 વાગ્યા સુધી competencies અને skills શીખવાડતા હોઈએ છે. So it is a marathon run when we have NRP to be trained, to be organized at our institute. But she has very beautifully summarized all the key points which we as a examiner ask in exam. એટલે એ ધ્યાનથી વાંચ્યું હશે ને અથવા સાંભળ્યું હશે તો તમને મેજોરિટી વસ્તુ આવડી જશે. સો રિમેમ્બર ધીસ. ઓકે, સો કરેક્ટ એપ્લિકેશન ઓફ umbilical cord clamp is very important. એક anecdote I would like to say over here. I was during our NICU round, I was seeing our patient, and one sister from maternity ward or postnatal ward, she rushed to the NICU with the clamp in situ, right? So she said, I am newly posted and I don't know how to apply umbilical cord clamp. તો એવી પરિસ્થિતિ ના થવી જોઈએ. એઝ અ ડોક્ટર, ઇફ યુ આર ઓલ preparing for your MLE or preparing for your NEET and you are under a rotatory internship, તમે જ્યાં LRમાં પોસ્ટેડ હો, આટલી એક વસ્તુ શીખી લેજો કે તમારી ડ્યુટીમાં ડિલિવરી થાય તો એક કોર્ડ ક્લેમ્પ અવશ્ય લગાડજો. ઓકે, સો deferred cord clamping, as we have discussed this, I will skip this. Cleaning of the baby, again we will preserve vernix for the want of hypothermia prevention. Placement of identity band is very important. Each infant must have this band with mother's name, hospital registration number, gender and birth weight. બહુ ઝઘડા થાય. They don't want to accept female babies. બરાબર? સો કોઈ એજ નામનું બીજું મેલ બેબી હોય ને તો એ લેવાના ઝઘડા થાય પછી. So this is important to show whenever you are posted in periphery also, remember this thing, okay, document this. You may come under a medico-legal scanner anytime for all these issues. So baby swapping, baby snatching, code pink, these are all very important medico-legal issues. Okay, routine care, madam has described, so we will skip this. Transitional care again. Okay, WHO recommends delaying first bath to be delayed at least first 24 hours. That is WHO mandate, right? But what we as a pediatrician, we say that at least till the cord is fallen, the submerging of the baby should be avoided. Barabar? You can just sponge bath the baby, and every alternate day, if the season is cold, you can do almost twice a week, and in this season you can do it on alternate day. But remember this thing, delayed the first bath. Okay, routine medications, again madam has told, we don't give beyond vitamin K and the vaccines to the normal newborn baby. Okay, screening, cord blood screening. કોર્ડ બ્લડનું સ્ક્રીનિંગ કેમ થવું જોઈએ? અત્યારે તો કોર્ડ બ્લડને પ્રિઝર્વેશનનો કન્સેપ્ટ છે. પીપલ આર પ્રિઝર્વિંગ પ્લેસેન્ટા એન્ડ કોર્ડ બ્લડ, એની બેંક્સ છે. Because we still have babies with RH iso immunization. તમે લોકો જે બુક્સમાં વાંચતા હશો, we are seeing patient, we are seeing babies dying. Immune hydrops fetalis વાળા બેબી હજી મરી જાય છે. We are losing newborn baby who are having RH iso immunization. So if the blood is sent just at delivery, we can find out what is the depth of involvement, depth of iso immunization, how much damage it is causing, how much hemolysis has occurred. That can be immediately managed, right? So it is very important to send bilirubin, blood group, CBC and DAT, that is direct antiglobin test. Routine assessment, again this has been discussed. Okay, initiation of breastfeeding. This is the ચાવીને ફેંકી દીધેલો ક્વેશ્ચન છે ને, એવો ક્વેશ્ચન છે ને તોય નથી આવડતું છોકરાઓને. લિટરલી યુ કેન ટેક પીક ઓફ ધીસ. સાયન્સ ઓફ ગુડ પોઝિશન અને સાયન્સ ઓફ ગુડ અટેચમેન્ટ પૂછાય જ છે. તમને એવું લાગે ને કે આ બધું મને આવડી ગયું છે ને હું બોલી ગયો છું, પણ એક્ઝામિનર જ્યારે આ પ્રશ્ન ઉપર આવે ને ત્યારે એવું વિચાર લેજો કે તમે આગળનું બરાબર આન્સર નથી કર્યું ત્યારે આ પ્રશ્ન પૂછ્યો છે. કારણ કે કશું જ ના આવડતું હોય ને અને પછી ચાલ આ તો બોલ, હવે આ તો આવડતું જ હોય ને, રાઈટ? સો ધીસ ઇઝ વેરી ઇમ્પોર્ટન્ટ. પોઝિશન ઓફ ધ બેબી, હોલ બોડી શુડ બી સપોર્ટેડ, નોટ ધ નેક ઓર શોલ્ડર. હેડ એન્ડ બોડી શુડ બી ઇન વન લાઇન. baby's body should be turned towards mother's abdomen and baby's nose at the level of mother's nipple. These are common breastfeeding positions: laid back, cross cradle, cradle, football hold and side lying position. Signs of good attachment. આ બી નથી આવડતું. લાઈક આ તો પહેલાથી બી ગયેલું આ ક્વેશ્ચન છે. પોઝિશન તો કોઈક બેબીને પોઝિશનનું પૂછીએ, પણ જો બેબી એ વખતે ફીડ કરતું હોય અને એક્ઝામિનર ભૂલે ચૂકે આવી ગયું કે આને અટેચમેન્ટ બતાવે તું, તો આ તો બહુ જ કોમનલી આ ક્વેશ્ચન છે. સો રિમેમ્બર ધીઝ ઓલ 4 ક્રાઇટેરિયા. ધ માઉથ શુડ બી વાઇડ ઓપન, ધ nipple and areola, most of it should be in the baby's mouth. Chin of the baby should touch the breast and lower lip is everted. Okay. So this is how the baby is latched. એક હોમવર્ક આપું છું તમને. લેચ સ્કોર વાંચી લેજો. લેચ LATCH લેચ છે ને, આ એનું એક સ્કોરિંગ સિસ્ટમ છે. લેચ સ્કોર તમને પૂછશે નહીં, પણ ઇટ વિલ હેલ્પ ઇન યોર આન્સરિંગ ધીસ ક્વેશ્ચન, because it is actually a PG question. Okay, rooming in, mothering in, bedding in, these are also common definitions which are asked. Discharge criteria આવડે છે કોઈને? આપણે હવે બર્થથી લઈ અને અસેસમેન્ટથી લઈને હવે ડિસ્ચાર્જ સુધી પહોંચી ગયા છે. તો કેન એનીવન સમરાઇઝ વોટ આર ધ ડિસ્ચાર્જ ક્રાઇટેરિયા? નોર્મલ ન્યૂબોર્નના ડિસ્ચાર્જ ક્રાઇટેરિયાની વાત ચાલે છે. So this is a core competency. You have to counsel and educate the mother on the care of newborn, explain follow-up care, breastfeeding, temperature maintenance, immunization, growth monitoring and red flags. Right? This covers all 5 parameters of essential newborn care. So AAP, American Academy of Pediatrics recommend, we have NNF guidelines also, but they are more or less the same. Clinical course and physical examination has no abnormality. Infants' vital are within normal range. Infant has normal urination 6 to 8 times in 24 hours and passed at least one stool spontaneously. The jaundice is absent. Breastfeeding is well established. Mother is confident in feeding the baby. Infant is adequately evaluated and sepsis is ruled out. Maternal and infant lab test has been reviewed and parental competency is demonstrated. Family is assessed. Danger signs. Most common danger sign: difficulty in feeding or poor feeding, refusal to feed, convulsion, lethargy, fast breathing, chest indrawing, yellow palm and sole, and temperature more than 37.5 or below 35.5. Ek terminology I have used while telling you definition. Significant hypothermia. યાદ છે? એની કટ ઓફ છે 35.5 degree Celsius. Less than 35.5 is significant hypothermia. Right? So there is some degree of moderate and some degree of severe. They all are included in significant hypothermia. A CAM છે that you have to Google. Okay, so this is the latest immunization chart. National immunization schedule, what sir was mentioning. You have to mug up the schedule. There are few changes which has been introduced. So there is third FIPV which is introduced, and there is also PCV third dose. Okay. Common parental concerns. See sir, parental concerns will be always be there, be it a normal newborn, be it a sick newborn. Okay, so you have to always counsel the parents and reassure them depending on the baby's condition. Okay, so these are very commonly encountered during postnatal round: regurgitation, not enough milk, frequent stool, and you have to guide the mother regarding the baby status. Skin to skin contact, it has been described. Zero separation policy, what madam said, right? Keeping mother and baby together helps in better temperature regulation, less stress for the mother, and successful breastfeeding. So these theory reading I have written. Now your theory is over. પણ તમને વાઇવામાં આ વસ્તુ પૂછી શકે છે. So you have to go through these competencies. Hemorrhagic disease of newborn શું છે? Hypoglycemia, hypocalcemia, seizures and sepsis. So go through the theory of this which can be asked as viva. Thank you for your patient hearing.
Now on a Wednesday 2 to 4 we have ophthalmology practical revision class. 4 to 6 on Wednesday same day. 4 to 6 gynecology practical revision class. And on Thursday surgery practical revision class. For medicine and other subject we will update you in the group. There is a small refreshment arrangement is there outside this auditorium. You can leave. Thank you all of you and best of luck.